Right. Can everyone see me? Hey, Sachit is here. Hi, Sachit, after a long time. Who else is here? Shabib is here. Okay. Yasser, you're from, where are you from? Huh? Ayush. Yeah, Ayush is here. Oh, Arshin is here. Okay, good. Okay, so some of you might be knowing me. Some of you might not. This is probably your first time joining. So welcome. I'm Prashan, for those of you who don't know me. So we've been teaching guys since about late 2018, right? That's when we started our initial program. We started off with something called Medicine 101. And then after COVID, we stopped for a while. We had some exams and some other work to do, some internships to do. And now we are back, right? So welcome all of you. Now, a few things before we start, okay? One thing, guys, I want you all to interact with me. Okay, I want you all to unmute and talk. Don't worry. It doesn't matter if you're in the first year. It doesn't matter if you're an intern student. Everyone here is equal to me. So if I ask a question, try to come up with some answer. No wrong answers here. It's okay. Just try to interact. Keep talking because, guys, you all realize when you're coming for your vivas and all, it's all a communication game. So I want you all to have these words fluently in your mouth, right? Okay. Right. Okay. So any questions before we start? Guys, just before we start, do we have any first years here today? Because in the registration, there was only one first year. Any first years? No first years? Tarushika, which year are you in? Fourth, fifth, fourth. Okay. So we have Ayush, third year, yes. Okay. Sachit, which year now? Huh? Doctor?
Just graduated.
Right. Okay. Excellent. Right. Okay. Habib, which year now?
Yes, graduated.
Third year. Okay. Excellent. So you all have attended before. I hope you all remember some stuff. So I'll ask some questions from you all also. Okay. Right. Let's start, guys. So the basically, right, what we are going to do, just an overview. Today and tomorrow, 2 sessions, ischemic heart disease. Today is going to be basics, right? Tomorrow is going to be advanced medicine, right? Doesn't matter if you're in the first year. Still, today's content, if you all are joining today, today's content will be enough for you all to handle tomorrow's advanced stuff, okay? And tomorrow, specifically the 4th and the 5th years, I don't want you all to miss. Even if you all have any friends, tell them to join because so even we've gone through the vivas, right? And there are some important tips and tricks that we want to give to you all, okay? Right, okay, let's start off. So what is our topic, guys? Ischemic heart disease. Just, guys, you all can see the whiteboard, right? Everyone can see the whiteboard, all good? Right. Is it inverted? No, nothing wrong. Right, okay, good. Ischemic heart disease, okay? Ischemic heart disease. Now, guys, don't be shy when I ask questions, Okay, ischemic heart disease. When you all hear the term ischemic heart disease, what comes to your mind? What do you all know? Anything you all know? Anything at all? What is an ischemic heart disease, guys? Interactive. Let's be interactive. Let's talk. Don't worry.
Lack of oxygen.
Lack of oxygen where to?
To the heart.
To the heart. Okay, heart. Excellent. Who answered?
It's me, Shiza.
Oh, okay. Right. Okay. Right. Listen. So, when we are specifically talking about ischemic heart disease, guys, we are talking about something to do with oxygen, just as you all said. If we look at oxygen, specifically with regards to our heart, right, there is something called an oxygen demand and an oxygen supply. Okay. Now, the problem in ischemic heart diseases, guys, right, there is either one, an increased demand of oxygen, right, by the heart, or a reduced supply, right, or a reduced supply. This is the basic I want you all to understand, right? So before we move on forward, tell me let's just talk through some terms. What do you all understand by ischemia? What do you all understand by the word ischemia? What is this? Anything? What is ischemia?
Lack of blood.
Lack of blood supply, right? Lack of reduced blood supply, what we call here, guys. Now, when we say ischemia, we are actually talking about several concepts, right? One is obviously when there is a reduced blood supply, there is going to be reduced oxygen, right? Everyone agrees with that, reduced oxygen. Then the other thing is when there is reduced blood supply to any place in your body, right? What is going to happen with regards to nutrition supply? That is also going to be reduced, correct? The nutrition supply is also going to be reduced. Nutrition supply reduced. Then the other thing when it comes to ischemia, guys, we are talking about, you all know, right? We have our arteries coming and dividing into the capillary network. We have the arteries, arterioles, then the capillaries, right? And then the venules, right? It will get into the venules and finally into the large veins. That's how our blood flows now, right? So here we have the blood coming and perfusing, like what we call tissue perfusion, giving out all the nutrients, right? Doing all the stuff there. And here at the venular end, this will take up all of these things, right? What do we call this, guys? Washout of waste, right? Waste product washout. So when we are talking about ischemia, guys, when there is reduced blood coming this way, there is also going to be reduced waste washout, right? And this is the third thing. When we talk ischemia, oxygen reduced, nutrition supply reduced, and waste washout also reduced. Okay, everyone agrees? Any question up to this? Right? Simple concept, right? Okay. Then, before we move on, now we said oxygen is being reduced. This is what? Hypox. Hypox, guys, we have two hypoxes. What is this? Hypoxia and hypoxemia. What's the difference? What's the difference? Huh? Hypoxia and hypoxemia. What's the difference? Anyone? Yes, don't be shy. Answer. What is hypoxia? What is hypoxemia? Touch it.
Hypoxia is lack of oxygen. Hypoxemia. Don't remember.
It's based on the location. It's based on the location. Hypoxia is lack of oxygen in tissue, right? In cellular structure, in tissue. Hypoxemia is lack of oxygen in blood, right? Specifically in blood. Okay, that's the difference. So hypoxia, hypoxemia. Just get clear with those words. Now, when there is reduced perfusion, guys, right? What can we, when there's ischemia, there's reduced blood supply. So we said there's reduced O2. Initially, there is hypoxemia, reduced oxygen in the blood, which can then go to hypoxia, right? For the tissues, right? Tissues aren't getting blood, right? Okay. This is one basic concept that I want you all to understand. Everyone clear up to this point, right? Guys, you all can take notes as we go, unless I tell you all at certain points to not write, okay? Until then, you all can just keep on writing, no issue. Right. Then the next concept. Now I asked anyone here first year, I'm assuming there is not, right? Everyone here clear about the concepts of systole and diastole? Everyone? Just give me a thumbs up. Just show me a thumbs up. If you all know what systole means, if you all know what diastole means, right? Okay. So everyone, I'm hoping everyone understands. If not, just either open the mic and talk or drop me a message. Huh? Okay. So systole is contraction. What we talk about contraction. Diastole is relaxation. And that we have atrial and ventricular. Right? But generally, when we are talking in medicine, when we say systole and diastole, we are talking about ventricular systole and ventricular diastole. Right? Everyone agrees? Right. Then, let's go to the next part. Now, I'm going to tell you all, when we talk about ischemic heart disease, 98% is causing ischemia of the left ventricle. Left ventricle. Okay? Left ventricle. Why is this the case? Ischemic heart disease, 98% occurs in the left ventricle. Why is this the case? Anyone care to guess? Or if you all know, why?
Because the oxygen pumps into the left ventricle because of the lungs.
Oxygen pumps into the left ventricle because of the... No. What I'm asking is now, when we talk about ischemic heart disease, what is ischemic heart disease? There is a lack of, there's either an increased demand or a reduced supply to the left ventricular myocardium. Therefore, the myocardium becomes ischemic. Now we are saying 98% of ischemic heart diseases occur in the left ventricle, right? Now I'm asking you why? Why is this the case? Okay, we're getting some messages. Guys, it's better if you all can, because it's difficult for me to open the chat box. Just talk. Don't worry. No one's going to judge you. Okay. High pressure system. Okay, good. Yes. Right. Look at this, guys. We'll talk one by one. First thing, when we take the when we take the heart, right? Let me draw a rough diagram here. So this is the left atrium, the left ventricle, right? And right atrium, right ventricle. When we take the ventricle, specifically the ventricular myocardium, guys, okay? Specifically the ventricular myocardium, which ventricle has the thickest muscle layer? Which one? Answer quickly. Left ventricle.
Yeah.
The left one. The left ventricle has the thickest myocardium. Why do you think this is? Why do you think this is? What's the reason?
It's supply more blood. to the body.
Yes, the left ventricle has to pump blood to the entire body, entire rest of the body. Left ventricle is the guy pumping. Right ventricle just pumps to the lungs, right? Okay. So look at this, guys. The first reason is the thicker myocardium, right? Thicker myocardium. So actually, guys, if we are looking at the left ventricle pathologically, if you take a sample and if you check the left ventricular myocardium, this one is about 1.5 centimeters. Okay, about 1.5 centimeters thick versus the right ventricle being only about 0.5 centimeters. Right, very thin. Right. So thicker myocardium means what in terms of demand? What do you all think? Demand is higher. Oxygen demand is higher or lower? Higher. Oxygen demand is higher because when there is a thicker muscle, there are a lot of muscle cells. There are a lot of muscle cells in that portion. So that myocardium requires higher amount of oxygen. So the demand is going to be high. This is one reason why ischemic heart disease majority occurs in the left. Can you all now guess and tell me or come up with some hypothesis and let me know any other reason? Based on the function, based on how things are working, anything? No? Rajit? Shabib? Huh? Right. Okay, let's go. Second reason is, guys, now, what did we talk about the pumping out of blood? The left ventricle has to pump blood to the entire body, right? So what do you think about the systolic blood pressure required for the left ventricle to generate? What do you think? Is it higher or lower? It's higher compared to the right side. It is higher. So when we look at systolic blood pressure generation, right? Generation, this will be a higher blood pressure, that is a higher systolic blood pressure needs to be generated in order to pump out all that blood to the rest of the body. So for example, guys, if you take the systolic pressure, the peak systolic pressure in the left ventricle, it's about 130 millimeters of mercury. Whereas in the right ventricle, if you look, only about 25 to 30, right? So 100 more, right? Okay. So the pressure generation that is required by the left ventricle is high. Therefore, again, demand is high. Any other reason? Any other reason? One more reason. If you all know, guys, if you all have seen muscles, let me take like a cut portion from here. Okay. I'll take a cut portion from there. It will look something like this. The myocardium, right? The myocardium. And inside we have the myocytes, right? I will draw it like this. And in between, guys, we'll have some blood vessels also, right? You can see the red. Yeah. Okay. Some blood vessels also, and some outside also we'll have some blood vessels. Huh? Right. So this is a rough structure, rough sketch, right? Now, what do you all know happens, guys, when a muscle contracts? What happens to a muscle when it contracts? In terms of length, what happens to it? When a muscle contracts, length. Guys, answer. Don't be shy. Talk with me. Sounding like someone who hasn't been in social gatherings for a long time. Right, look. What happens to muscle length? Shortens or lengthens? What happens? Shortens. Good. Yeah, show me like that. Right, good, Sachin. Right? So muscle length will shorten. Right? What happens to muscle bulk? Just contract your biceps and see. Bulk increases. Muscle bulk increases. Muscle length shortens. Right? So this, if I draw it here, it will look something like this. Right? I'm saying after contraction, it will look something like this. Right? Correct? Everyone agrees? Inside, if you look at the structure, guys, each individual myocyte has also bulked up and shortened. Okay? This is during muscle contraction. Everyone agrees? Right? Then, what do you all think happens to these blood vessels, guys? What do you all think? These blood vessels, they get squished. Can you all see? Right? these blood vessels get squished like this. Okay, everyone agrees, right? Now tell me, if this is happening like this, right? When is the cardiac muscle contracting? During systole, right? During systole. So what do you think happens to the ventricular blood supply during systole? What happens? If the blood vessels are being squished, what happens to the ventricular blood supply during systole? Guys, don't be shy. Answer. Now I'm going to ask one by one. Only 4 cameras are turned on. Difficult, difficult to. Who is here? Satsarani. Can you answer? What happens to the blood supply to the ventricle during systole? Guys, by the way, if there is any connection issue, any problem, message. We have a co-host, Sharud is here. You all can message her. Just message her and let me know. Let her know. She will attend to it. Okay. Right. Okay. Look. During systole, what happens? The blood supply to the ventricle is slightly cut off. Okay. Why? Because the muscle cells, they bulk up. Therefore, the space for the blood vessels are lost. So the blood vessels are squished. So the blood supply is cut off. Everyone agrees with this, right? Okay. If this is happening, guys, right? During systole, if the blood vessels are squeezed, what is happening to the blood supply? Blood supply is going to be reduced. So in a ventricle, in the left ventricle specifically, which ventricle has a stronger force generated during systole? Left or right? We just talked about the left, right? Excellent. So if the left is generating that much of force and that much of contraction, the blood supply cutoff to the left ventricle is much higher during systole than to the right side. Okay? Than to the right side. So during peak systole, guys, the left ventricle will have reduced blood supply more than the right ventricle. So this is the third reason, right, that we have 98% of ischemic heart disease happening in the left ventricle. Okay? Everyone agrees? Right? Right. Then the next concept, right? The next concept. Now, which blood vessels specifically supply blood to the heart, guys? Which blood vessels? What is the name of the vessel? Anyone? Guys, someone answer. That is difficult, Difficult for me to teach you. Coronary arteries. Excellent. So coronary arteries, right? Coronary arteries. So specifically, guys, when we are talking about ischemic heart disease, we have to think there is some problem with the coronary arteries, right? This is why we call it also coronary artery disease. Exactly what the disease is, we'll talk about in a little bit. Okay? Coronary artery disease, right? Now, let's look at what is causing this problem. Here, guys, before we move forward, I will tell you all, just know for now, more than 90% of ischemic heart disease is caused by something called atheromatous, right? Atheromatous plaque, right? Atheromatous plaque. Okay, we'll talk about what this is. Don't worry. Atheromatous plaque. Okay. We'll leave this aside for a moment. We'll come to this later. What are the other possible causes? What else can cause a reduced blood supply to the myocardium? Just try to think and come up with some hypothesis. Apart from this atheromatous obstruction or this atheromatous plaque, what else can cause a reduced blood supply to our myocardium that can give rise to this ischemic heart disease? Any guesses? Anything. Come up with anything. It's okay, right? I want you all to think. Embolism. Okay. Which embolism? Can you be a little bit more specific? From where? Where did the embolism arise from? Anything?
DVT.
DVT. Good. Deep vein thrombosis. You all have heard of this, no? Deep vein thrombosis, specifically when you've had a long term of travel or you haven't moved your legs for a long period of time, right? There can be clot formations. There are some risk factors associated with it, including age, right? But what happens is from the leg vessels, they will originate, they will move up, right? And they will come that cause pulmonary embolism, whatever. Okay. Anything else? What about reduced supply, guys? Now we're talking about specifically about reduced supply. Reduced supply of blood. Severe hemorrhage, right? What we call a hemorrhagic shock, right? So if a patient is in hemorrhagic shock, again, there is a risk of acute cardiovascular events like ischemic heart disease, right? Okay, specifically myocardial infarction, we'll talk about later. Okay, anything else? Anything else? aortic dissection. What is aortic dissection, guys? What is aortic dissection? Guys, now you all know if we take the aorta, right? If we take the aorta, there is multiple layers, guys. There is the tunica media, tunica intima, media, adventitia, right? The 3 layers, right? So if you look, if I draw it like this, right? Like this. This is the blood supply going this way. In the middle, this is the vessel, right? So this is the tunica intima, right? Tunica intima. Here, guys, sometimes due to certain factors, aortic dissection is not our topic today, but there are some risk factors associated with it as well. There can be intimal ruptures, right? There can be small intimal ruptures, right? So what happens? Blood starts entering these areas, okay? Blood starts entering these areas and blood can keep dissecting the intima, guys, right? Either way, upwards or downwards, both can happen, okay? So blood can enter into these areas. Sometimes blood can rupture the media, right? Go into the media as well, right? So this is aortic dissection. Specifically, guys, we are talking about aortic dissection. If I draw the aorta like this, right? If I draw the aorta like this, let's say the dissection started somewhere here, okay? Dissection started somewhere there, and then it kept dissecting. It kept dissecting the intimal layer separated from the media, coming all the way here. You all know where the coronary artery starts, guys. The coronary artery starts just below the point of the, what is this valve? I drew a valve here. What is this valve? This is the left atrium, left ventricle. You all have to get used to my drawing also. These are also 2 valves, and these are 2 valves. What is this valve?
Aortic valve.
Aortic valve. Okay, everyone's clear about that now, right? I'm afraid to go for. Just below the aortic valve, guys, we have the point where the coronary arteries start. Okay. So if the aortic dissection comes all the way down here, just beneath and it dissects its way up to the base of the coronary artery, that can again result in ischemic heart disease. Okay. Everyone clear? Everyone understood? Right? Right. Good. Then, anything else? Anything else you all know? Have you all heard about something called
the hypertrophy of the left ventricle?
Good. Hypertrophy. Excellent. So hypertrophy. When does hypertrophy of the left ventricle occur? Hypertrophy of the left ventricle. When does hypertrophy occur? Any examples? We'll talk about this in heart failure chapter. Yeah.
Yeah, arrhythmias.
Arrhythmias. Okay. Mainly, guys, hypertrophy, one of the main causes is, there are 2 types of hypertrophy, right? One is called eccentric hypertrophy, one is called concentric. Don't write this. This is not today's chapter. We'll talk about this later. Okay? We'll talk about this in the heart failure chapter. There is something called eccentric and concentric hypertrophy. Concentric hypertrophy occurs when there is a pressure overload, what we call a pressure overload. Okay? And eccentric hypertrophy occurs when what we call a volume overload, right? Volume overload. Either way, when there is a hypertrophy, you're correct. The demand, because when there is hypertrophy, what happens? There is usually hypertrophy followed by or accompanied with hyperplasia, right? Usually that's the case. So when there is hypertrophy with hyperplasia, there is often an increased demand, right? Again, so there can be a heart failure-like condition and again resulting ischemic heart disease, right? I agree. But more than that, we'll talk about that in heart failure. Don't worry. Have you all heard of something called Prinzmetal angina? Prinzmetal angina. What is that? Any words you all have heard about it? Anything? Who are the seniors? Sachit? Prinzmetal angina. Prinzmetal. This is, guys, what we call a vasospasm. What is a vasospasm, guys? What is a vasospasm? Don't worry, these are fancy words. Fancy words too, just scare you all. A vessel has become spastic. Okay? A vessel has become spastic, contracted, constricted. Okay? This is a vasospasm. This Prinzmetal variant angina, guys, specifically is, now let's say this is the normal coronary artery. Here, what is happening in Prinzmetal angina, there is no obstruction, no atheromatous plaque, nothing wrong with the vessel, but due to some reason, right, the vessel constricts. The vessel goes into spasm. Vessel goes into spasm. So what do you think about the blood supply? The blood flow will be cut off, right? Blood flow will be cut off. So that we'll talk about this more. We'll talk about this more when we come to the diagnostics because we need to differentiate this as well. But for now, just know there is a condition called Prinzmetal angina. where there is only vasospasm. If you do an angiogram, now what is an angiogram, guys? We put a catheter to the patient's arterial system, usually the femoral artery, comes all the way to the heart, and we can look at the specific fat blob or the atheromatous plug, right? That is the angiogram. In Prince metal, what will you see if you do an angiogram? What will you see?
ST segment elevation.
Angiogram, not ECG. We're not talking about ECG. Angiogram, what will you see? You will see nothing. Okay? You will see nothing. There is nothing wrong in the angiogram when you do, right? It's a negative result, right? That is why we'll talk about how to differentiate this using the ECG and the biomarkers, right? We'll talk about that later. For now, just know this word, Prince metal angina, vasospasm, coronary vasospasm. Everyone clear up to this point. So we have talked about some causes. What can cause ischemic heart disease, right? Okay. Now we'll see how this is happening. What's the underlying mechanism? What is happening here, right? What is happening in this ischemic heart disease, right? Okay. Look at this.
Also,
guys.
one more thing for transmetal angina, you can say it's a like heart pain at rest, like cardiac pain at rest. Isn't transmetal angina also known as the cardiac pain at rest, like
cardiac
without
pain
exertion?
At rest. Yes, we'll talk about that because we have there is stable angina, unstable angina, and Prince metal angina. So when we talk about Prince metal and the unstable variants, there is pain at rest, right? Don't worry, we'll talk about those in the diagnostics. Okay. For now, we'll go ahead with the pathophysiology, right? Good. Right. Now, what is exactly happening in this ischemic heart disease, guys? Look at this. Let's do this, right? I want you all to take a piece of paper and just draw this structure. Let me erase this also. All right. Just draw, let's draw 4 of these. So I'm taking a blood vessel. And I'm cutting this portion and I'm taking it here. Okay. So it will look something like this. Like this. Okay. This is a cut cross section of the blood vessel. Okay. I hope y'all can, my art is not the best, but we manage, right? So just draw 4 of those, right? Okay. Then another one. All right. Okay. Something like this. Okay. Now, what is happening here? Okay. All good. So this is a blood vessel. More specifically, let's consider these to be cross sections of a coronary blood vessel, coronary artery, right? Okay. Look at this, guys. There are some risk factors. We'll talk about these risk factors in a little bit. For now, just leave it there. Due to some risk factors, guys, right? What is going to happen? There is what we call repetitive vascular endothelial injury. Vascular endothelial injury. Now, you all know, guys, when we take a vessel, right? This innermost cell layer. Here we have an endothelial cell layer, right? Okay, inside the innermost cell layer, right? So this is the same thing here. There is going to be repetitive vascular endothelial cell injury, right? Due to the risk factors. We'll talk about what these risk factors are. Don't worry. Now, when there is a injury to cells anywhere in your body, who comes there? Or what type of cells come there, migrate to that area? Basics. We'll go with basics. Unmute and talk, guys. Who's here? Hey, just talk. What types of cells will come here? When there is some injury? Yes, sir. Which year are you in? Which year?
Graduated.
Oh, graduated. Which university?
Prashan State Medical in Russia.
Good. Okay. So when there is a vascular endothelial injury, what types of cells come here?
Pages.
White blood cells. More specifically, we like Macrophages. Macrophages love to come to these areas, guys, to come and see what is there to eat, right? Macrophages, all they do is eat, okay? And then there will be also some platelets coming in, right? Some platelets will also arrive at this area, right? And they will try to correct whatever injury is happening here, right? Now, the problem is, guys, these risk factors that we are going to talk about in a little bit, these are chronic risk factors, long-term risk factors. So this vascular endothelial injury keeps happening over and over and over and over again, right? So eventually what is going to happen, guys, so much of these macrophages and all are going to come into this area, and they are going to start entering this vessel wall. The macrophages will be entering this vessel wall, okay? They initially come to the damaged sites, and then later with chronic repetitive injury, they will even start invading into the vessel walls, okay? And what is going to happen, guys, here in the vascular, in the vessel walls, we have what you call smooth muscle cells. Smooth muscle cells, right? Smooth muscle cells. When these macrophages come here, guys, they start what we call recruitment of smooth muscle cells. Recruitment of smooth muscle cells, right? Just fancy terms, guys. What do we mean by this recruitment? These macrophages come, they produce some cytokines, right? They produce some cytokines, right? Which causes hyperproliferation of these smooth muscle cells. This is what we basically mean by recruitment, right? More and more smooth muscle cells are being produced here, right? Okay. Now, at the same time, we said these macrophages are producing some cytokines. What do those cytokines do? Apart from recruitment of smooth muscle cells, they also call for more and more macrophages. So further macrophages are coming in. More and more macrophages keep coming to this damaged area, right? And they start eating into these, into the vessel wall, right? They start eating into the vessel wall. Okay. Now, right? Then, guys, with this going on for a long term of time, what is happening? There is going to be some irregularities, right? What we call intimal irregularities, guys, right? More, if I draw it more, can you all understand? It's like a 3D, sort of like a 3D structure that I'm trying to draw here, right? This wall becomes irregular. Now, it was initially a nice flat, nice wall, like this, if you take like this, the cross section. But now, after period of vascular endothelial injury, recruitment of smooth muscle cells, more macrophages coming in, damaging the endothelium, this wall becomes something like this, right? So if you take the cross section, it's like that, right? Like that. Okay, you all understand? Let me draw that better here. Something like this. Okay. Yeah. Okay. Right. This is what we call, guys, intimal irregularity. Okay. The intima becomes irregular. Right. Now, when there are intimal irregularities, now, guys, tell me. Anyone? Okay. All of y'all here are between the age of, I'm assuming, 20 to 40, right? No one above 40 is joining us today, I'm assuming. Right. Okay. So y'all are young, active people, right? If you take a sample of blood and let it settle for a while, right? Specifically, if you had a meal, right? Let's say an hour ago, and if you take your blood out and just let it be for a while, will you see any fat in your blood? Will you see any layers of fat in your blood? Let's say you centrifuged it. Will you see any layers of fat in your blood? What do you all think? Huh? Yes. Okay. Okay. It doesn't matter if you all are very young. If you all want to stay young. Still, if you take your blood and specifically after a meal, guys, specifically after a meal, if you centrifuge it, there will be a tiny layer of fat. There is always some fat also in our blood. The content is there. Now, what happens when there are intimal irregularities like this? When the blood is flowing, guys, the fat can start depositing on these irregularities, right? The fat can start depositing on these irregularities like this. Okay, right? The fat will start depositing. Okay, right? These are what we call, guys, fatty streaks. Fatty streaks. Okay, fatty streaks. Right? Okay. Right? Then, what happens, guys, further after some time, continuously when these fatty streaks are being formed, little by little, lots of fat starts depositing and they start forming what you call fatty blobs, right? Like an entire, let me draw it here like this, like an entire blob of fat. right? The fatty streaks will coalesce together. There will be large blobs of fat after a period of time. Okay. Now this ischemic heart disease, guys, based on this, what we learned up to now, do you all think it's just a one-day event? No. These pathological changes usually go on for a while before the patient starts coming and manifesting ischemia, right? Okay. So these fatty blobs, this is the last step. Now look at this, guys. We said the smooth muscle cells start hyperproliferating, smooth muscle cell recruitment. Smooth muscle cells, guys, what do normally smooth muscle cells do in a blood vessel? Normally, smooth muscle cells, guys, they are involved in vasoconstriction, vasodilation, as well as repair, right? Endothelial repair. So what do these smooth muscle cells do? They like to produce collagen, right? They produce a lot of collagen, right? Collagen. Now what happens when there is overactive smooth muscle cells? There is so much of collagen produced. Some of this collagen will come and envelop this fat lobule. Okay, some of this collagen will come and envelop this fat lobule, right? Like that. What is this, guys? What is this? So what do we have? We have what we call this. We call it the lipid core. The lipid core, and this what we call the fibrous capsule. Fibrous capsule. This lipid core plus the fibrous capsule together, they make up what we call the atheromatous plaque. Atheromatous plaque. Okay, this is our atheromatous plaque. A lipid core surrounded by a fibrous capsule. Everyone clear up to this? All good, right? So this is our basic. This is our problematic fellow. This is the guy. Now, if we diagnose, guys, if we are able to, by some means, diagnose all of these steps before the patient starts developing atheromatous plaque, we can essentially cure ischemic heart disease. But that is not the case. We do not know, right? I'm pretty certain, including myself and some of you all also, we might be somewhere along this path. Okay, right? That's the problem. That's the issue we have, right? Everyone understood up to this? Yes, there is a message. Guys, just talk. That's the recruitment of smooth. Yes, there is inflammation as well, but specifically we are not mentioning inflammation, guys, because we'll talk about inflammation. There's something called plaque shoulder inflammation. We'll talk about that when it comes to unstable angina, right? Don't worry, I will go step by step. Okay. But yeah, good question. There is some inflammation going on, but why I didn't mention that word is there is a specific inflammation that we have to talk about later. Okay. Don't worry. If you all have any questions, just unmute and talk. Huh? Right. Everyone clear? Give me a thumbs up. Give me a thumbs up. Right. Excellent. Right. Now, we said, guys, there are some risk factors. What are these? What are these risk factors? Right. This is what we are going to talk about. There are, guys, if we take risk factors, there are some fixed risk factors. Fixed. Right. And there are some modifiable risk factors. What are these fixed risk factors? Modifiable. Okay. Fixed risk factors and modifier. What are these fixed ones? What do we mean by fixed risk factors? We cannot do much about them, right? They're already there. Cannot really be helped. What are these? One, age, guys. How is age a risk factor? What they have found out is, guys, we don't know exactly why, right? But if you take a patient, an individual less than 40 years of age, less than 40, everyone here, I'm assuming, right? Your risk of developing an atheromatous plaque that leads to ischemic heart disease is less than 1%. Less than 1%, right? But still, there is a bit of a chance, okay? Right. The next thing, if you take an individual between the age of 40 to 60, this percentage jumps to about 5%. Okay? This is just age as a risk factor. We don't know what exactly the mechanism is, but there is an association. If you take a person greater than 65 years of age, guys, this jumps to about 25%. Okay? About 25% of the individuals above the age of 65 have a high risk of developing ischemic heart disease, right? So this is one fixed risk factor. We cannot really do anything about it. Next thing, sex. Ischemic heart disease is most common in whom? Males or females? Any idea? Answer. I have to interact. Shabib? Most common in? Sorry? Males, right. Yes, guys, males with a small caveat, right? Look at this. Until the menopausal age, right? Males are more than females. Until the female menopausal state, males' risk is higher than females. after menopause, males and females equal, right? Equal risk. What does this tell you? What does this tell you? What is protecting females? Estrogen. Estrogen. Estrogen is a protective factor for ischemic heart disease in females. Okay. Just know that as a fact, right? Then, next thing, family. If we look at family history, guys, there are some fixed fam history. There are some fixed risk factors here as well. For example, guys, there are young onset ischemic heart disease, right? Young onset ischemic heart disease that runs in families, right? There are some obstructive heart conditions also, something like you all might have heard HOC and POCM, right? Hypertrophic obstructive cardiomyopathy. These things tend to run in families, right? So those kind of disease, and there is another one called familial hypercholesterolemia. Familial hypercholesterol. Your dad has hypercholesterol at a young age. You also have, right? So these kind of risk factors they are also fixed because there is a genetic component that we can really not do anything about. Okay, right? So there are some family conditions as well. What you have to ask, why I'm telling this? Why is it important? In your history taking, you have to ask about these, right? What can you ask? Have you had first degree family relatives who have suffered from any young onset ischemic heart disease, any young onset heart problems, right? These are questions you have to ask in your history. Okay, right? Let's move on. So these are the fixed risk factors. What are these modifiable risk factors? Now tell me, Dr. Khan, you all know all of these. Huh? Anything? What are the modifiable risk factors? Huh? What?
Diet, exercise.
Diet, exercise. Okay, these are now diet and exercise. We don't say that they are a risk factor. They are what we can do, right? Those are what we can do. When I say modifiable risk factor, a risk factor, specifically, guys, first thing, smoking and alcohol, right? Very easy. Smoking, alcohol, right? Modifiable risk factor. Another thing, diabetes, hypertension, dyslipidemia, right? Very, very common associations. So these are modifiable risk factors. Why modifiable? We can take some medication and try to control them, right? Okay. Next thing. Have you all heard of something called metabolic syndrome? What is metabolic syndrome, guys? What is metabolic syndrome? Metabolic syndrome, guys, this is when we say syndrome, it's a group of disorders. No, here there are multiple things, guys, right? So for you all, when you get a patient to your ward, you must be able to visually assess as well as from the history assess, is this patient likely having metabolic syndrome? What are you going to look at? First thing, guys, obesity. Obesity. Specifically, we are talking about abdominal obesity. What do we mean by abdominal obesity? Waist circumference, right? Waist circumference, guys, if it is more than 40 inches in a male, right? Or more than 35 inches in a female. Huh? Now, no need to check. Huh? No need to check. Check later, right? If that is there, high risk, right? Abdominal obesity. And you can also add BMI, but why we don't say BMI specifically, guys, there is a lot of variation with BMI. You all must be knowing, no, right? If there is a person who is regularly going to the gym, and taking protein powders and all of that, we cannot assess the BMI. Pregnancy, we cannot assess using BMI, right? So BMI also, you can say generally more than 25 is considered high risk, right? But there are some caveats there you have to be careful. Then, if you do a lipid profile, guys, do we have any second years here? Do we have any second year students here? No one? All I'm assuming third year. So Ayush said third year. So I'm assuming everyone's third year and above, right? Okay, clear. So you all should know what a lipid profile is. What do we do in the lipid profile, guys? What do we check for? What are the things we look at in the lipid profile? Okay. Huh? Sorry?
HDL and
HDL, LDL, what else? Triglycerides. These are the main three, right? TG, HDL, LDL. Now, if we say, you all might have heard the colloquial terms, good cholesterol, bad cholesterol. Huh? What is the good cholesterol and what is the bad cholesterol? Triglycerides and LDL. Triglycerides and LDL are the bad ones, right? HDL, we generally consider it as the good cholesterol, right? Good cholesterol. So if you do a lipid profile, guys, and you see that the triglycerides have elevated, plus or minus, HDL has dropped, right? Plus or minus, HDL has dropped. This is our diagnostic for dyslipidemia, what we call dyslipidemia. Okay, there is an imbalance between good and bad cholesterol. More specifically, if you all want the values, triglycerides more than 150, right? Triglycerides more than 150 is for the intern students. It's okay for you all to know the values. Huh? It's good if you all know the values. And HDL drop less than 40, right? Less than 40 in a male, less than 40 in a male, right? And less than 50 in a female. 50 in a female, right? Okay. So HDL reduced or triglyceride increased. This is another risk, high risk. Then if you look at the fasting blood sugar, guys, right? Usually we say diabetic if it's more than 126, no? But here, if it is if it is more than 100 mg per dl, we take it as high risk, more than 100 mg per dl. This is again metabolic syndrome, right? Then the other one is, guys, hypertension. If you take hypertension, systolic blood pressure and diastolic blood pressures, right? Systolic more than 100 and let's say more than 130, right? And diastolic more than 85, right? More than 85, right? So these are again, all of these, guys. If the patient has any three of these, right? Any three of these, we consider them having metabolic syndrome, and metabolic syndrome is a very high risk for ischemic heart disease. Okay, everyone clear? Right. Then, so we talked about smoking, alcohol. We talked about diabetes, hypertension, and dyslipidemia. Then, guys, what else? What are any other modifiable risk factors along with smoking and alcohol? Another thing that people can take that can cause a risk for ischemic heart disease. Think. No? Drugs, huh? Cocaine, right? Heroin, right? These are also there. Okay. Very important, guys. Very important. Specifically, now, yesterday I was speaking to one of my friends who is now working in the US. He's in his residency. And now you all know in US, majority of the states, they have legalized marijuana for use. Okay. So he had this patient coming in with a chest pain, same chest pain, ischemic heart disease. And he even walked into the hospital smoking marijuana, right? And he's offering that to my friend as well. He's like, do you want some? Right? So, yeah, very funny. Anyway, next thing. Psychological stress, emotional stress, all of these can also cause, specifically if the patient is depressed, right? If they're on antidepressants, when you're taking your history, you can ask about other medications, right? Are you on antidepressants? These kind of things, right? So apart from that, there are other comorbidities, guys. For example, thyroid diseases. There is some association between hyperthyroidism, increased basal metabolic rate. Not very important, right? The main risk factors that I want to talk to you all about is diabetes, hypertension, dyslipidemia, metabolic syndrome, and then smoking and alcohol. Okay, these are the main things I want you all to focus on, specifically when taking history. Okay, understood? Clear up to this point? So those are the risk factors. Now, so we created the fat blob, right? The atheromatous plaque, right? We discussed the risk factors. Now we'll see what this atheromatous plaque is doing to cause ischemic heart disease. Okay, right. Guys, brains are not overloaded yet, no? We just talked about some basics. Everyone's okay, comfortable? All good? Is the speed okay? Right? Am I going too fast, too slow? Just let me know, right? I want some juniors to start talking, Even the registrations, guys. So we had over 15 graduate students registering, Okay. So good. But yeah, good. Okay, right. Let's move on. Look at this. Now we'll look at this atheromatous plaque. Right? What is this guy doing here? Atheromatous. Again, someone tell me what an atheromatous plaque is. What is an atheromatous plaque? What is an atheromatous plaque? How do you define it? Two words. Tuck. Guys, talk with me. Excellent. Right? Lipid core and the fibrous capsule. Right, good. Look at this, guys. Now, when we look at this atheromatous plaque, if I draw a blood vessel, right? Something like this, right? And we have the basal layer, right? And I will draw the plaque somewhere here. Like this, right? That's atheromatous plaque. And then you all know we have a fibrous cap, right? A fibrous capsule, right? And the lipid core, right? So this is this. Okay. Right, you also can draw, huh? Right. Here's the lipid core. Yeah. Okay. All right. Now, look at this, guys. When we look at these atheromatous plaques, right? There are two types of plaques, right? There are two types of plaques. What are these two types? One is what you call a stable plaque. Stable plaque. And the other one, obviously, as the name suggests, unstable. What do we mean by this, guys? What do we mean by this? A stable plaque. A stable plaque, guys. This is a long-standing plaque. This guy has been there for a long time, right? A long-standing plaque. He has a very thick, write this down, huh? Stable plaque. It's a long-standing plaque, okay? Very thick capsule. He has a very thick capsule, okay? Very thick capsule. And it is firmly fixed, right? Stable plaque is what? Long-standing plaque, thick fibrous cap, firmly fixed, right? Now, these stable plaques, guys, right? They are going to have some adaptations. We'll talk about that in a little bit. Now we'll go to the unstable plaque. What is an unstable plaque? Exactly the opposite of stable plaque. What do I mean by exactly opposite? Fibrous cap is thin or thick? Thin or thick? Thin fibrous cap. Good. Thin fibrous cap, right? Then there is, guys, in an unstable plaque. Now I will draw this as an unstable plaque. Huh? In unstable plaques, guys, there tends to be what we call fissuring, right? Fissuring, small cuts, small damages in this plaque surface, right? Small damages in this plaque surface like this. When there is fissuring and these small ruptures, what is happening, guys? Who is here in the middle? Who is here in the middle? This is what? This is our, what is this? The lipid core, right? So when there is fissuring in an unstable plaque, this lipid core is exposed to the blood. Lipid core is exposed to the blood. This lipid core, I want you all to know, very thrombogenic. What do you mean by thrombogenic? Likes to form clots, right? Likes to form clots. So what is happening, guys, when this lipid core is exposed like this, this guy is going to call a lot of platelets to come here, right? And form aggregates, right? We call this a thrombus, right? This guy will form thrombus. Okay. So what is the next feature of an unstable plaque? One was it has a thin fibrous cap. It has fissuring and ulcerations, lipid core exposed, and we have thrombus formation. So when there is an atheromatous plaque with a thrombus on top, what is happening to the blood flow? Severely obstructed blood flow. Okay. This is an unstable plaque, right? Okay. Everyone clear up to this point, right? Then another thing I want you all to know, guys. Now, what did we say? There is fissuring, there is ulceration. So this lipid core is exposed, right? When this lipid core is exposed and the platelets come and start forming the platelet plug, right? There are some substances produced, right? This is in hematology, guys. We'll talk about this. If you all have joined my hematology module 2-3 years ago, we talked about these. Platelets, when they are aggregating, right? They produce some substances. One is thromboxane A2, right? Anyone below the third year, I don't expect you all to know this today, right? Just know the term, right? Thromboxane A2, right? Then there are some other things for when platelets want to aggregate and combine with each other, right? There is something called glycoprotein 2B, TA. Just write this down, guys. Why I'm telling you all this? When we come to the management, we'll see what we can do about these molecules. Okay. For now, just write them down, right? So when these platelet plugs are forming like this, they will start producing various substances, right? And there will be some what we call vasoactive substances, right? One is specifically, guys, called vascular endothelial growth factors. Okay, VEGF, right? VEGF will also be produced, right? Just know these three: thromboxane A2, glycoprotein 2B3A, VEGF, right? Look at this. Now, tell me this, guys. Your organs in our body need blood, so we have blood vessels to transport blood to them. Do our blood vessels need blood? What do you all think? Our blood vessels will transport blood to an end organ to receive blood. What do you think about our blood vessels? Do they also need blood? What do you all think? Yes. Blood vessels receive blood from a smaller group of blood vessels, guys, right? They are surrounding these vessels like this. These are called vasa vasorum, right? Vasa vasorum. Okay. So our blood vessels also receive blood through this vasa vasorum. Okay. Now what happens when this vascular endothelial growth factor is increased in these areas, right? In these thrombogenic areas, this vasa vasorum starts growing rapidly, right? Vasa vasorum specifically starts growing rapidly around this site, right? Okay. Specifically, just imagine this plaque as like a volcano, as a 3D structure, like a volcano, like this. And around this, right, the vasa vasorum starts hyperproliferating. This is what we call the plaque shoulder, guys, right? The area around the plaque is called the plaque shoulder. Okay. So this vasa vasorum starts hyperproliferating around the plaque shoulder, right? When vessels are hyperproliferating, when there is a lot of blood supply coming to an area, along with all these cytokines being released, what is happening? There is what we call plaque shoulder inflammation. Around this plaque, around the shoulder, there is inflammation going on, right? In the 2D view, it's this area, right? It's this area, okay? In the 3D view, it's all around. Huh? I hope you all understand, get that picture clearly, right? So there is what you call plaque shoulder. So this is the next feature of unstable plaques. There is plaque shoulder inflammation. Okay. Did the stable plaque have any of these? No. Stable plaque was just a long-standing plaque, nicely there, staying on its own, thick fibrous cap, no fissuring ruptures, nothing, no exposure of the lipid core, nothing. It's just staying there. This unstable plaque is the problem. Now, what do you all think, guys? If there is a mass here, this is the fact, this is our atheromatous plaque, and around that is being inflamed, right? What do you all think about the cellular integrity around this area? It's going to be weak. This plaque, guys, it can even sometimes dislodge and travel and embolize somewhere else. Okay, with the thrombus, right? With the thrombus on its head, right? Like that. Right? This guy can go and embolize somewhere, right? Because of all this inflammation that is going on. Okay, right? Understood up to this point? All clear? Give me a thumbs up. Right? Right. So now you all understand the difference between a stable plaque and an unstable plaque. Agreed? Right? All good? Right. Right. Now, guys, how is the patient going to come? Now, this is what's going on inside the patient's coronary vessels. How is the patient going to come to us? How is the patient going to come to you all? I'll leave that for a while. How is the patient going to come to us? Now there is an obstruction. Let's say, okay, let's forget the stable and unstable. Let's just say there is an obstruction in the coronary arteries. How is the patient going to come to you? What is he going to come and tell you? What is his chief complaint? Chest pain, right? Very simple. Chest pain. Here, guys. Now we will go into, I will erase this. We'll further differentiate this, right? Patient is going to come with chest pain, right? So what do we have? We have ischemia, right? Ischemia leading to chest pain. Chest pain. Now, look at this. When there is chest pain, guys, what is the fancy word to say chest pain? If you want to scare your patients, when the patient comes with the chest pain, what can you tell him? You have angina pectoris, right? Okay, right? That's what you can tell. Just to scare the patient, this is what we call, guys, angina. Angina is pain. Pectoris is the chest area, right? Pectoris, right? Angina pectoris. Here, guys, there are two types. Right? One is called stable angina. Stable angina. Then we have Unstable angina. Right. Now tell me, what do we mean by these two terms? What is stable angina? What is unstable angina? Who produces stable angina? We just drew a few minutes ago. Stable plaque, right? Stable plaque will produce the stable angina. Unstable plaque will produce unstable angina. Okay, clear up with that? Right. Now we'll look at what the differences are here, right? Here, guys, stable angina, if I want to tell you in one sentence, just remember, stable angina, stable at rest. Stable at rest. When the patient is resting, there is no pain. There is no pain. Stable at rest. Unstable angina, same way. Unstable even at rest. Unstable even at rest. Even at rest, there is going to be pain. Okay, there's going to be pain. Let's write it down. Huh? Right. Now we'll look what is happening. Right. Look at this. Angina pectoris. What is actually happening here? Angina is the early warning sign. Right. Chest pain is the early warning sign. The patient will come complaining of the chest pain. Right. Look at this. Say early warning. Now, when we talk about angina pectoris, guys, how will the patient describe the pain to you? How will the patient? Okay, let's talk about site. How will the patient tell you where does it hurt? Majority of the patients will say yes, chest pain, chest pain. But any specific location that you are looking for as the physician, as the doctor, what chest pain are you looking for? Yes, touch it. Yes. Crushing type of chest pain. Yes. That is the character. What about the site? Site. Well. Sorry?
Chest pain, maybe.
Chest pain? Sorry, I didn't. Radiating.
Yeah. Radiating.
Yeah. Oh, okay. That is again comes under the character of the pain. It's radiating to somewhere. We'll talk about that also. Where is the site? Chest? Yeah. You are satisfied with chest? When the patient says chest pain, are you satisfied? No. Retrosternal chest pain. Okay. Okay. Retrosternal. Some books they say substernal also. Same meaning. Substernal or retrosternal type of chest pain. Right. So just write these down, guys. The characteristics of this angina we are going to talk about. First is retrosternal. What is retrosternal? Behind the sternum. Behind the sternum, in the middle. Right. Then central. It's a central type of chest pain, right? Retrosternal and central. Okay. Then, yes, what you said was correct. This crushing type, right? Crushing type of chest pain. Crushing type of chest pain, right? Usually the patient will say, okay, he feels like something is tightening up inside. Okay. Right. Crushing type of chest pain. Then you tell the patient, guys, okay, show me. Now, when you all are working in the clinic, all right. Do we have any of you consume alcohol? Anyone? No? No? Okay, right? Look at this. Chronic alcoholics, right? Chronic alcoholics. Sometimes with cirrhosis, they can have cholecystitis as well. If they are coming with a cholecystitis is different, they can usually pinpoint the pain. But due to cirrhosis, due to fatty liver, due to fibrosis, if they are coming with some liver-related pain, have you all met any patients like that? How do they come and tell? Entire right side here pain, right? Same case with this, guys. Visceral pains that are coming from viscera. Okay. Pain sensations arising from viscera. It's difficult to localize for the patient. If you tell the patient, show me where the pain is with one finger. Majority, 98, 99% of the time, they will just say this entire area, right? Entire area is pain, right? So you should be tactful when you are taking the history. So here you say, usually cannot localize with the finger. That's the next characteristic. Usually cannot localize, right? Cannot localize with a finger, okay, with one finger. Then yes, Sachit, you are correct. Radiation is the next feature. Radiation, where to? Sachit, where do we radiate to? Where is the pain radiate?
Shoulder, jaw.
Okay. Shoulder, jaw, where? Left, right, where?
Left.
Left shoulder, okay, left. What about the arm? Anywhere in the arm? Guys, specifically say medial aspect of the arm and the forearm. Okay, medial. This is the medial side now. You all know this is the medial side. The medial aspect of the arm and the forearm, shoulder, yes. Jaw, neck, right? Left jaw, left neck, all of that. Correct. Huh? So there can be radiation of the neck. Sometimes radiation to the back as well. Because I met a patient when I was in my internship, very confusing. right? He kept on saying radiating to the back, like he feels the pain at the back. So my mind was entirely on what's the differential? Pain, chest pain radiating to the back, intrascapular area. Seniors.
Yes, gastritis or
Gastritis, correct, but gastritis is not a crushing type of pain. Gastritis is a burning type of chest pain, right? More than that, there can be a crushing or a crushing type of chest pain radiating to the intrascapular area, guys, in aortic dissection, right? Just know that for now, not today's topic, but aortic dissection, huh? Right. So anyway, they can tell, patients will tell multiple things, guys. So the history itself is usually insufficient for us. We need to do an ECG, we need to check the biomarkers, but we can get a clue. Okay, we can get a clue, right? Right. So retrosternal crushing, cannot localize, radiates, right? Everyone clear up to this point? Right. Now, so this is our early warning, guys. What do we mean by this early warning? There is some lack of blood supply to the heart at this point. That's why the patient is feeling the pain. If this is not managed timely, what will happen to the cardiac myocytes? What will happen to the muscle cells? What will happen? This is early warning is what? Ischemia. What will happen if this is not managed, guys? With time, we will have death, right? Necrosis of cardiac myocytes. When the cardiac myocytes start dying, this is when we call it an infarction, right? Infarction. So myocardial, specifically MI, we say myocardial infarction. Okay, clear? This is what the layman's heart attack is. Okay, heart attack, myocardial infarction. Right? Then there are some other clinical features, guys, some autonomic features also we are going to come across. We'll talk about that in the diagnostics part. Don't worry for now. For now, I want you all to have this basic idea. Everyone clear up to this point? All good? Thumbs up? Right? Excellent. Guys, others also turn your cameras on. Who is here? Kavindu Vijay Sundara. Manari Mullen. No, I just want to see your beautiful faces, so that I can continue the class. Right? Okay. Just don't be afraid of answering. Okay, guys, don't send messages in the chat. I won't be able to read. Yeah, just unmute and talk. Okay, right. Then now, what's another? Now, what do we say, guys? Infarction. What is infarction? What is infarction? Tell me again. Cardiac myocyte necrosis. Cardiac myocyte death. Right. Now, let's say, guys, if I draw this. I'm telling you all, this part of the heart has died. This part of the myocardium has died. Okay, this part of the myocardium has died. Let's start with ischemia before we go to death. Now we said this part of the myocardium is undergoing ischemia. That was the first step, no? That's why the patient comes with chest pain, no? Right? Ischemia. If there is ischemia, if there is lack of blood supply, there is also lack of oxygen. If there is lack of oxygen, how is the metabolism going on in this area? Aerobically or anaerobically? What do you all think? There's going to be? Any idea? Sajid? Yes, anaerobic, right? Anaerobic metabolism occurs here. So if it is anaerobic metabolism, specifically, guys, there is going to be anaerobic glycolysis occurring here, right? When there is anaerobic glycolysis, what is happening? We are having a lot of H+ ions, hydrogen ions being produced, right? Hydrogen ions and lactic acid and all of that is also happening. But these hydrogen ions, they will always compete with calcium. They will always compete with calcium for the cardiac myocytes. You all know muscle contractions, guys, calcium is essential, right? Calcium is essential. So if hydrogen is competing with calcium, what is going to happen to this portion, this specific portion of the myocardium with regards to contractility? What is going to happen? It is going to be reduced, right? Actually, unmute and talk, right? It is going to be reduced, right? I can't lip read. Okay, it is going to be reduced. Now, if it is going to be reduced, what is your diagnostic test to see that reduced movement? What can you use to see that reduced movement?
ECG.
Okay, ECG a little bit more specific than ECG. A little bit more specific than ECG.
Oh.
Echocardiogram. Excellent. Echocardiogram, right? The echocardiography will show you reduced movement, right? This is what we call, guys, hypokinesia. hypokinesia of the wall. Okay, don't worry, we'll talk about this more in diagnostics. But for now, I want you all to get the basic understanding, right? So there can be ischemia. Because of that, there can be anaerobic glycolysis, and the affected part, including after even infarction, right? In infarction, it will be completely not moving at all, right? So basic concept is the affected part, their death occurs as well as hypokinesia occurs. Everyone clear up to this point? Right? Okay. Good. Tatsarani, which year are you in? 1, 2, 3, 4? 5. Ah, good. Okay. Right. Okay. Good. Right. Then let's move on. Now, guys, we talked about stable plaque. We talked about the unstable plaque, and we mentioned the angina as well. Right. Look at this. Now, how is the patient coming to us? Right. So we have the atheromatous plaque. Right. Then you all can write this down. Huh? Same thing I'm writing now. We have the stable plaque. We have the unstable plaque. Right? The stable plaque gives rise to what we call, guys. Now, the stable plaque, based on what you all have heard about the stable plaque, do you think it is a sudden emergent condition? The stable plaque? Yes or no?
It's a chronic.
Yes, this is what we call, guys. We can call it chronic ischemic heart disease. Chronic ischemic heart disease, right? Whereas the unstable plaque is our acute emergency. This is what we call acute coronary syndrome, ACS, right? Acute coronary syndrome, right? So the chronic ischemic heart disease produces what? Stable angina. What is stable angina? We'll discuss more specific details, but for now, what we know, it is stable at rest. When the patient is resting, there is no pain, right? We'll talk more specific details more. ACS, guys, acute coronary syndrome, there are multiple entities here, right? One is obviously from our unstable plaque, we are getting what we call unstable angina, right? Then if the ischemia continues, right, and no management is done, what happens? Infarction. So that is the second one, myocardial infarction, right? Myocardial infarction. Here, guys, based on the ECG, don't worry, we'll discuss. There is a ST elevation myocardial infarction and a non-ST elevation myocardial infarction, right? We'll discuss, don't worry, right? And there is also another ECG finding, guys. We'll discuss about this. Just write it for now. New onset, left bundle branch block, right? We'll talk about that. Right. And finally, sudden cardiac death. This one, guys, we are not going to discuss, right? Why aren't we going to discuss this? Patient is already coming to us, right? Dead. Okay. So there's nothing much we can do there, right? These three we can try to manage. Okay. Understood? Right. We'll come back here, guys, to our stable angina. What do we know? Stable at rest. Here, guys, again, I want you all to write a few points here. What is the stable angina? Again, this is just write down, retrosternal crushing type of chest pain. Same thing, retrosternal crushing type of chest pain. Here, the important point is, guys, pain provoked, right, by exertion. Pain is provoked by exertion. Okay. Pain is provoked by exertion. Or sometimes, rarely, emotional stress also, right? Emotional stress. Not very common, but possible. Okay. Pain is provoked by exertion. Right? The next most important point. Pain is relieved by rest. Or what we call a group of drugs, guys. We call them nitrates. Don't worry, we'll talk about how they work. Okay. Pain is relieved by rest or by nitrates. Okay. So this is our stable angina. Okay. Right. Now, tell me, guys, why is this pain relieved by rest? And why is it happening at exertion? This is what we are going to talk about next. Why? Why do you all think? Just think about the structure of the stable plaque that we talked about and try to come up with some hypotheses, some theories, Guys, I want you all to think. I want you all to think. Passive learning, not very useful. You all have to think and come up with stuff. Now, why do you think this pain, stable plaque, is producing a pain only at exertion and at rest it's fine? Why? Think. Think and answer. Give me an answer.
Stable plaque does some narrowing in the vessel, so only when there's exertion, only there's a more demand.
Right.
So
Good.
the narrowing.
Right. Such it. Good. Now, stable plaque does some narrowing. More specifically, what I want you to say is, yes, you're correct. But what is happening, guys? When there is a plaque, more than true, even the unstable plaque will cause some narrowing of the blood flow. But what I want you to specifically say, this plaque area, guys, cannot vasodilate. Okay? This is the main point I want you to understand. Why do I say that? Now, let's say this is a vessel, right? This is a blood vessel. During exertion or during any activity, a muscle requires more blood. A muscle demands more blood. Therefore, what happens? This vessel dilates, right? This vessel dilates, right? During exertion. But when there is a plaque here, this portion with the plaque, it cannot vasodilate. It will remain the same. Cannot vasodilate. So more than saying it vasoconstricts, what I want to say, it cannot vasodilate. Okay? Understood? Clear concept, right? So wherever there is a plaque, wherever there is a stable plaque, during exertion, the plaque area will not vasodilate. So that is the first reason. The first reason I want you to write down. First reason, plaque area will not vasodilate during exertion. Okay? Right? Then, the second one. Right? Second one, guys. Now, let's say you all are exerting yourselves. You all are doing some physical activity, right? Some running. Okay? Nothing else. Some running. Now, when you all are running, what is happening to your heart rate? What is happening to the heart rate? Heart rate increases. For your heart rate, now you all know, guys, your cardiac cycle, right? Systole, diastole. Systole, diastole. This is your cardiac cycle, no? This is how it goes, no? Right? When your heart rate increases, right? Which one do you think now? This has to happen more frequently, no? This has to systole and diastole. It has to happen more frequently when your heart rate increases. Which time, the systolic time or the diastolic time, shortens? What do you think? For your heart rate to increase. Diastolic time reduces. Is everyone clear on that concept? Right? Diastolic time reduces. So when so it will be something like, we'll draw it more. Systole will remain the same, diastole reduces. Systole the same, diastole reduces. So this will be the diastolic time. Right? So diastolic time reduces, right? While the systolic time remains the same when there is increased heart rate. Now tell me this. Our cardiac muscles receive blood during what period? We talked this initial at the start. Our cardiac myocytes receive blood in the systole or diastole.
Systole.
Diastole. Why? Why in the diastole? Why not in the systole? Talked about today. Huh?
Because in systole, the heart muscle is compressed, the blood vessels are compressed.
Excellent. During systole, blood vessels are compressed, constricted, therefore blood supply drops. So now what is happening, guys? When the heart rate increases, the diastolic time reduces, and the time there for perfusion of our heart starts dropping down, right? The time for perfusion of our heart muscle cells start going down. This is another reason why during exertion, the stable angina patient presents with chest pain, but when he's resting, his diastolic time is normal, is enough perfusion for the cardiac muscles, so he does not have any pain. Everyone clear with that? Give me a thumbs up. Clear with that? Okay. Tatsarani, clear with that? Thumbs up. Right. Okay. Excellent. Then, third reason. Right? Third reason. What is the third reason, guys? Third one, I want you all to know, guys, the stable plaques, they have what you call collateral formation. So if the plaque is here, it's a long-standing mature plaque, right, with a thick fibrous cap. So this guy has been there for a long time. What happens, guys? He will form some, with the help of these vascular endothelial growth factors and all, he will form some collateral circulations. So now the blood can go through these, right? Blood can go through these and come here, right, and keep flowing, right? Now, what do you see? What do you see as a striking feature of these collateral vessels, guys? Are they the same size as the coronary artery? No. Collateral vessels are smaller vessels. They are weaker vessels, right? They can rupture easily as well. So when there are smaller vessels, right, and weaker vessels, during rest, it is fine. During rest, it is fine. But during exertion, can these small vessels vasodilate enough to perfuse sufficiently? Not really, right? So this is a third reason why during rest, the stable patients are fine. But as soon as they exert themselves, they get the chest pain. Everyone clear about these three reasons? Right? Okay. Right? So these very common questions, guys. Very common questions in the Viva. Okay. I will tell you all later some of the questions that I also got. Okay. You all know your basics, guys. That's all they're testing. Don't worry. Don't worry too much. Especially Viva. Written theory papers are a little bit different. You all have to know in depth. But Viva, basics, huh? Right. Then. Now, let's move on. What did we say, guys? Okay. Relieved by rest or nitrates. What are these nitrates and what are they doing? How do nitrates prevent chest pain, guys? This specifically coronary artery related ischemic chest pain. How? What is happening?
Vasodilation.
Sorry, vasodilation. But, okay, good. Vasodilation. I like your point. But what did we say about the vessel with the plaque? Can it vasodilate? No. Then what is happening? How do you all think? This relieving pain. Come up with a hypothesis. Huh? Invent something for me. What do you think? This is, guys, what happens is nitrates don't specifically vasodilate that obstructed part. No, it cannot. It cannot vasodilate the plaque area. But what nitrates can do is it can vasodilate the systemic circulation, right? Arteries can be vasodilated and there is venous dilation as what we call venodilation, right? Venodilation and arterial dilation both occur, right? So when there is, let's say there is a lot of systemic vasodilation, okay? When the systemic blood vessels, specifically the veins, are very dilated, what happens to the capacity in those veins? Blood storing capacity in those veins increases. Good. That's it. Unmute. I'm lip reading. Huh? Okay. No lip reading here, right? The ability for them to store blood in the vessel, we call this venous pooling, guys. A lot of blood can pool in the venous system, right? So what is happening? Less blood coming here. Less blood coming into the right ventricle. Less blood going to the lungs. Then from the lungs, less blood is coming to the left side of the heart, left ventricle, and less blood is coming. So if there is an overall reduced amount of blood that is coming to the heart, what do you think about the workload of the heart? Workload of the heart will reduce. So this is how nitrates reduce the chest pain, right? Nitrates, guys, they cause systemic vasodilation, specifically venodilation, thereby causing reduced workload of the heart. Okay, everyone understood? Right? So these nitrates, guys, this is why we use them as antihypertensives as well, specifically in emergent conditions. This is why we can use them, because there is a vasodilation action that they can do. So they are classified as both antihypertensive and an anti-anginal, because it reduces the pain as well. Okay, understood? Right? Okay, give me a thumbs up. Right? Give me a thumbs up. Right. Okay. So we've done most of the complex part. Now look at this, guys. We'll talk about, let's go to the next part. Everyone clear up to this, right? I'm going to erase the board. All right. Right. Anyone here joining from Sri Lanka, or is everyone abroad? Huh? Or is everyone from different countries? Yes, sir. Which country are you from?
Sri Lanka.
Sorry?
Sri Lanka.
Sri Lanka. Okay. So you're currently in Sri Lanka or you're abroad?
I'm abroad.
You're abroad. Okay. So no one's undergoing the heat wave. I'm dying here. Very hot, guys. Very hot. Okay. Right. Then let's go on. What happens now? Let's specifically look at the cardiac muscle. What happens there, right? We'll take a look, right? Cardiac muscle. Right? Cardiac muscle. Here, guys, I'm going to draw something like this. I'm going to take a portion of the cardiac muscle, something like this, right? And I will draw a coronary vessel somewhere here so that, yeah, you can understand. Let me draw it bigger. Coronary blood vessel somewhere there, right? Now let's say, just for you all to get, so this is the, from inside to outside. Okay, if I take the heart like this portion is what I have taken here. Okay, this is the inside, right? Inside as in endocardium, right? Then we have the myocardium. Then here outside we have the epicardium including pericardium, right? Parietal, serous layers. No need to talk about those now. Just know endocardium, myocardium, and epicardium, right? Now, if I draw the structure like this, this is a coronary vessel, right? Coronary vessel is supplying blood to this portion of the myocardium, right? If there is an obstruction here, right? Which portion, endocardium, myocardium, or the epicardium? Which portion will get ischemic first? Which one?
Epicardium.
Now think about this, right? Look at this. I'll draw a leg, right? I'm telling you, there is a vessel that is supplying all the way up to this big toe, right? Big toe. There is a vessel supplying blood all the way up to this big toe. And I'm telling you, while going to the big toe, there are branches. So it's supplying to some other areas as well while it's moving. I'm telling you, here there is a small obstruction, right? Not 100% obstruction. Let's say about a little bit more than 70%, right? Now, which place will go, in simple terms, which place will go blue first? You all know when there is hypoxia, when there is reduced blood flow, limbs and fingers, they tend to go blue, right? Which areas? Let me mark them A, B, somewhere here C, and I'm saying here D. Which area becomes ischemic first?
D.
D. The most distal area will become ischemic first. Okay, this is the concept I want you all to understand, right? Because guys, now a little bit of blood is coming from here now. Little bit of blood still comes from here, right? And it's going to distribute those blood, and little by little, it's going to be fainter and fainter. Once it is reaching D, there is no blood to give at all, right? You understand? So the most distal part becomes ischemic first, right? So same concept here. When we take the coronary vessel and the myocardium, always, guys, right? The ischemia starts here at the endocardial area. Then if that plaque is not controlled, right? If the ischemia is not controlled, little by little, it will start spreading upwards to the other layers, right? Little by little. And finally, this entire thing can get ischemic. When the entire thing gets ischemic, guys, we call it a transmural ischemia. Okay? All the layers have got ischemia. We call it transmural ischemia. If it is only in the endocardium, we call it a subendocardial ischemia. Right? Everyone clear? Right? Okay? Right. Now, guys, then let's move on. Me draw another one. Right. What happens, guys? Now, what did we say? There is something called a subendocardial ischemia. Right? Specifically when there is a small obstruction here, right? What can happen, guys? If this ischemia is not controlled, we said the ischemia can spread, right? Causing a transmural ischemia. If that is also not controlled in time, what is the next step after ischemia?
Infarction.
Infarction. So here we can also have what we call an infarction, right? So infarctions, guys, what I want you all to know, infarctions also can be, right, either subendocardial infarcts or transmural infarcts. That will depend on how much the vessel is obstructed. Usually, if the vessel is 100% obstructed, right? Usually, if the vessel is 100% obstructed, there will be a transmural, full thickness infarct, right? Usually, if it is less than that, let's say about 50% or usually more than 70, there can be a subendocardial infarction. Okay, everyone clear after that? Here, guys. Now, so what are the four things we know? Transmural ischemia or transmural infarction, right? Possibilities. Then the other one, subendocardial ischemia or subendocardial infarction, right? I hope you all are clear with the terms infarction and ischemia. Infarction means what? Myocyte death. And there will also be hypokinesia. Right. Now, when you all are clear about that, guys, here's what I want you all to know. Whenever there is a full thickness involvement, what we call a transmural, right? If it is transmural ischemia or transmural infarction, whatever, we have in the ECG what we call an ST elevation, right? What is this ST elevation? How is it happening? We are going to discuss. Don't worry. For now, just know whenever the full thickness of the myocardium is involved, either ischemia or infarction, both, right? There is what we call a ST elevation. Okay. Right. Okay. With that introduction, we'll come to the ECG, the diagnostic part, right? ECG. Look at this, guys. When we take the ECG, right? When we look at ECG, guys, there is what we always call the isoelectric line, right? This line is at 0 millivolts, right? This is the isoelectric line in the ECG, right? And when we have the ECG pattern, the usual ECG pattern, you all know, P, Q, R, S, right? And then a T wave, like that. Okay, everyone's, don't worry. Later we will be having a ECG session sometime back. P, Q, R, S, T, right? Right. Guys, sorry, someone give me a second. Give me a second. Can you message this chat? You can't join the session or something. Right. Sorry about that. Right. Where were we? Yeah, PQRST. Right. Look at this. Now, what is this ST elevation? Here, guys, where the S wave transforms to the T wave. This is what we call the J point. J point. Okay. Don't worry, guys. ECG is a separate session, right? I will be doing that, right? A separate ECG session, starting from the very basic. Today, we don't need to go through all of that, right? We'll just do what is important for our class today, right? So this, where the S transitions to the T, we call this the J point, right? Now, what do we mean by an ST elevation? ST elevation. Now, just note, I'm not writing STEMI, not MI. We are just talking about ST elevations in the ECG, right? So what do we mean by a ST elevation is, guys, this J point has risen above. What do we mean by that, right? So if I draw it something like this, right? ST, something like this. The J point is now somewhere here, right? J point has risen above the baseline. This is what we call an ST elevation. There is tomorrow in for the session tomorrow, we will be talking about what a significant ST elevation is, how many millimeters. We'll talk all about that advanced stuff tomorrow. Today, I want you all to know ST elevation means J point elevated, right? J point elevated. Okay. Then, guys, what do we mean by non-ST elevation? Non-ST elevation. What do we mean by this? Now, you all know what ST elevation is. What do we mean by non-ST elevation? Huh? What do you think? Any idea? No? Tell. Huh? Guys, talk. Turn on your cameras. I see only 3 cameras turned on. Yeah, that's it. What is non-ST elevation? What do we see here? Just look at ST elevation and tell me the opposite.
There is no ST elevation or depression.
Right. Okay. So here, what is happening is the J point is below the isoelectric line, right? That is basically what we mean by that. So here, guys, what you're going to see is, yes, you're correct. You can have what we call a ST depression. Sorry. Like this, a depression, right? We are going to see a depression. The J point is here. J point is here. Then continuing with the normal T, right? So this is the ST depression. Usually, guys, in non-ST elevations, we get the ST depression accompanied with a T wave inversion. This is the T wave. Most of the time, right? Majority of the time, the T wave is also inverted. T wave is also inverted. But doesn't have to be, not always, but majority of the time. Everyone clear about an ST elevation and a non-ST elevation? Now, what did we say about ST elevation? Whenever the entire thickness of the myocardium is involved, there is going to be an ST elevation. Okay, clear? Right. Then, now, another one. In the start, we mentioned something called a new onset left bundle branch block, right? Now, how this is happening, we'll discuss in a little, okay? But now just know, guys, in our heart, when we take our heart, right, you all know, here is the SA node, right? And then we have the AV node here, right? And then we have what you call the bundle of His, right? And then that comes and divides into two, actually into three. The left vesicle divides into another one, but let's take it as two, right? And we have the Purkinje system, like that, right? This is our usual conduction system of the heart, right? From here to here, right? Like that. Now, what is happening is, guys, in ischemic heart diseases, what did we say? Majority of the time, left ventricle is involved. Majority of the time, left ventricle is involved. With the involvement of left ventricular myocardium, guys, when there is reduced blood supply, this left bundle branch can also stop working, right? The left bundle branch can also stop working. This is what we call a left bundle branch block. Okay, don't worry about this. Tomorrow, right, we will be talking about how this is going to manifest, right? But now, just know this, guys. There is a left bundle branch block in ischemic heart disease. And in certain other conditions, we have something called a right bundle branch block. But now just know the easy way to identify this in an ECG is what we call William, right? William pattern. What is this William pattern, guys? Now, what are the leads in the ECG? How many? These are now everyone's 30 and above now. I want you all to know at least what are the leads placed in the ECG. How many limb leads do we have? Answer, unmute and answer. How many limb leads?
One.
Sorry?
Two. One.
No. 1, 2, okay. 3. So, okay, look at this, guys. Okay, don't worry. We'll have an ECG session. We'll have a separate ECG session. I will be teaching all ECG. Don't worry about that. If you look at limb bleeds, guys, there are 3 main limb bleeds, right? And there are 3 augmented limb bleeds. Augmented limb bleeds also, there are 3. So total 6. But there are 3 actual, like real limb bleeds and 3 augmented limb bleeds. So the real ones are called 1, 2, and 3, right? The augmented limb bleeds are called AVL for left, right? AVR, right? And AVF for foot. Okay, these are augmented. A stands for augmented, right? Don't worry, we'll talk about all of this in another class. And then what about the chest leads? How many chest leads do we have? The small buttons we place along the chest? Yes, we have 6. We have 6 chest leads, right? V1 to V6. V1 to V6. Any other chest leads you all know about? Any other chest leads?
7, 8, 9.
7, 8, 9, looking at what?
Posterior.
Looking at the posterior aspect of the heart. Now, don't worry. We'll talk about all of these. Don't worry for now. Here, guys, what do I mean by this William? If you look at V1 to V6, so V1, there's V2, V3, V4, V5, like that, V6. In the V1 lead, in the ECG, the QRS complex will look something like a W, right? The QRS complex will look something like this. Then if you look at the V6 lead, the QRS complex will look something like an M pattern, right? Like an M pattern. This is not exact, guys. We will look at some ECGs, right? Tomorrow we will be looking at some ECGs, right? We won't see the exact W like this, but this M is of course quite characteristic, right? Anyway, tomorrow we'll be looking at some ECGs. Don't worry, I will teach you all how to read ECG. Okay. For now, just know this. Okay. So what are we going to see? In some cases, when the transmural full thickness is involved, we are going to see an ST elevation, right? In some cases, we are going to see an ST depression. We'll talk about when we are going to see those. And we are going to see what we call this left bundle branch block, right? Now, all of these won't come in all the patients. Okay. That's the other important thing I want you all to know, right? Okay. So that is regarding our basic ECG stuff that I want you all to know. Then guys, now, what did we say? Whenever there is a transmural involvement. What do I mean by transmural involvement? Either transmural ischemia or transmural infarction, right? Whenever there is a transmural involvement, there is going to be an ST elevation. Now, the next question is, how do we know that an infarction occurred? What test can we do to know if this is just an ischemia or an infarction, cell death occurred? How do we know? What can we use? Huh?
Cardiac biomarkers.
Cardiac biomarkers. What are these cardiac biomarkers? What are cardiac biomarkers?
Troponin I.
Troponin, yes. Okay. Yes. Those are examples of cardiac biomarkers. What is happening? How are they coming? How are they being released? What is happening?
When there's cardiac muscle death, those enzymes are released to the
Excellent. That's it. That's it. So whenever there is myocyte death, right, those enzymes will be released into the blood and you can detect them in the blood. So whenever there is infarction, right, whenever there is infarction or muscle death, that's when you will see the biomarkers elevated. Biomarkers elevated. So specifically, guys, what are the cardiac biomarkers you've heard of? What are the cardiac biomarkers you've heard of? Do we have any students from India? Any students from India? No? Okay, anyways, because I know they use some different biomarkers there. Anyway, what are the biomarkers, common biomarkers there? Yeah, Ayush, yes. Can you please unmute? What are the common biomarkers you all use there? Cardiac biomarkers. Any idea? Any clue? The third year, no? I don't expect you to know. Okay, anyway, it's okay. Just end it. Right? Look at this, guys. The common biomarkers we are familiar with is troponins. Troponins. Yeah. Okay. Troponin I and troponin T. These are the common ones, right? Troponin I and troponin T. Apart from that, there is also something called, guys, creatine kinase, PK. PK, guys, specifically, we are looking at the myocardial band. Not other, there are different types of CKs. No? We are looking at the myocardial band, that it is MB, CK-MB, right? So troponin I and T and CK-MB. Now, actually, guys, in Sri Lanka, right, we use something called HS troponin, high sensitivity troponin, HS troponin, right? So this is, I mean, right, we have it in Sri Lanka, meaning we have it in all over the world, right? But you all have to be updated because a lot of books don't mention this, right? Especially old books, right? So this HS troponin is a little bit new, but this is what we usually use now, right? Now, those days, now, if you all have learned in your current syllabuses, you all, in your older syllabuses, what you all have learned, guys? Okay, which one is more specific? Which one, if I ask you, troponin versus creatine kinase, which one is the more specific one? Guess. No wrong answers. It's okay. Even if there's a wrong answer, it's okay. Which one is more specific and more sensitive? Answer.
Troponin.
Can you repeat the question?
Yeah, troponins. No, I asked which ones are more sensitive and more specific, right? Yes, correct. Troponins, Shabib, good. Troponins are generally considered more sensitive and specific, right? Generally, guys, if we look at this, if we draw a graph, right? You all must have drawn these graphs previously also. Usually, troponins, they tend to be elevated. Like, let's say they start elevation around 4 to 8 hours, right? After about 4 to 8 hours of the onset of pain, you will see an elevation, and they will come down, guys, after a long time. Usually they stay up to 10 to 14 days, right? 10 to 14. They peak somewhere here. We'll say about 48 hours after the onset. after the onset, about 48 hours, they will peak and they will remain elevated in the blood for a long period of time. This is troponin. Whereas we have our TK, right? Creatine kinase. Creatine kinase, guys, it will elevate soon, right? It will elevate soon, usually within about 24 hours. It will elevate 18 to 24 hours. It will elevate, and it will come down also relatively rapidly, right? Usually by about 72 hours, guys, creatine kinase normalizes, right? Now think. Now I'm going to give you all a question. Now look at this. Based on this, now we said troponins are the most sensitive and specific, right? Let's say our patient had a myocardial infarction here, right? He had a myocardial infarction here. Then we checked the troponins. It was elevated. Fine. We diagnosed. Fine. Around day 5, somewhere here, around day 5, he's telling, doctor, I'm having a chest pain again. Now, based on this diagram, around day 5, he's having another chest pain. So what is your primary suspicion? What is your primary suspicion as the doctor? What is your primary suspicion? Same type of chest pain, retrosternal chest pain, everything the same. What do you think? Doctors, answer. Huh? What do you think? Guys, answer. Why you all are shy? Huh? Come on. Huh? Answer. What is your primary differential now? Around day 5, if he's saying I'm having a pain again. Shabib. Wait, I'm scared. Are you all scared of answering, or what is the problem?
Is it restless?
Oh, wait. Don't overthink. Don't overthink. Yes, restless syndrome is a possibility. All right. Restless syndrome, what type of pain will it be? Now, pricking type of pain. Don't worry. We'll talk about that later. Right? This is, I'm saying, he's complaining of the same symptom, same crushing type of chest. Guys, you know this in the clinical setting, right? Very important. If a patient who has had an MI, within day 4-5, if he's coming again with the same type of pain, this is a reinfarction. Majority, 95% of the time, reinfarction. Okay, another MI, right? Specifically, if PCI wasn't done, we'll talk about PCI later, right? These patients highly likely, right? Okay, so this is most likely another reinfarction, right? Reinfarction. Now, based on this graph, for the reinfarction, which of the biomarkers do you think is more specific, more sensitive, based on this diagram? For the reinfarction. CKMB. This is a very important question they love to ask. Okay. For a reinfarction, guys, CKMB is more specific. But for generally myocardial infarctions as a whole, troponin I and troponin T are the most specific. Okay. Why the reinfarction is more specific here? Because you all know here, by around 72 hours, by day 3, the CKMB dropped back to baseline levels. Whereas the troponins are still dropping down. They're still somewhere here. So if you see another rise, it might be something like that. You might even not notice it sometimes. But the CKMB, clearly, if day 5 there is another infarction, again it will go up, right? Clearly, you will see a nice elevation in the CKMB, right? That is more specific. Okay, everyone understood that point, right? Right. So now we are coming to the last stretch, guys. Home stretch of today's class, right? Look at this. Now, everyone give me a thumbs up. If you are going to faint, let me know. Thumbs up. Good. Who else is here? Right. Tarushika, all good. Tarushika, which university? Don't type. Unmute and answer. Tianjin, okay. Tianjin 50 year, no? Fourth year, okay. Tatsarani? Which university?
Dalian Medical University.
Dalian, good, excellent. Okay. Right. Then let's move on. Look at this, guys. Now, so now you all have understood about the ECG findings. Whenever there is cell death, we are going to get the biomarkers coming out, right? Now, guys, we will just draw this with me. We will draw 5 5 such portions and we'll compare, right? 5 myocardial portions. I want you all to draw this with me. Right? 1, 2, 3, 4, 5. Right? And draw the coronary vessel above it. Right? Right? Okay. Guys, is the speed okay? Is it too much, too fast, too slow? Anything? Huh? Give me a thumbs up if speed is okay. Teaching after 3-4 years? No, good. Okay. Right? Have to. Right? Problem is 3-4 years, global warming increased. I think. Very hot here. Right. Okay, everyone, do this? Right. Okay, look at this, guys. Right. We're going to talk one by one. What is happening? Right. First, our first scenario here is our stable angina. Stable angina. Now someone unmute. Okay. Someone unmute and tell me what are the features of the stable angina, the stable plaque. Don't look. Just think of the stable plaque. It's a stable plaque. From that name, what do you understand? Unmute and tell.
The lipid core and fibrous capsule are intact.
They're intact, okay. Okay. Anything else? It's a stable plaque. It's a long-standing plaque. Don't forget those words. Long-standing plaque, right? A mature plaque, right? And it's a fixed plaque, right? These words I want you all to get familiar with. Okay, right? Good. Lipid core is not exposed, correct, right? And the fibrous cap is thick. Right? All of those you understand. Now, so when there is a stable plaque like this, guys, there is going to be a slight obstruction to blood flow. Specifically at rest, the patient will be fine. But during exertion, there will be some obstruction to the blood flow, right? When there is an obstruction to the blood flow in a stable plaque, right? We are going to see what, right? Starting with the subendocardial region, we are going to see some ischemia, right? Now this ischemia, I drew it in green color. You also draw it in one color, right? Because I will be drawing ischemia in one color and infarctions in another color, right? So starting with the subendocardial region, we are going to have a slight ischemia, right? Now, when there is a slight ischemia in the subendocardial region, if you look at the ECG, will there be an ST elevation? No. Okay, I see you all nodding your head. No, good. Right. So if there is no ST elevation, what do we call it? A non-ST elevation, right? So these will be non-ST elevation. Don't write exactly what I'm writing, right? Don't put MI or anything. This is a non-ST elevation if you look at the ECG. Okay, ECG, right? Right. Then we'll come to the next one. Prinzmetal angina. This is our Prinzmetal. Prinzmetal, what happened, guys? Can someone tell me what is happening just very briefly? What is happening to this coronary vessel in Prinzmetal angina?
Vasospasm.
Coronary vasospasm. So there is here the obstruction is very severe, like way more compared to the stable angina. So here we get a transmural involvement of ischemia. Now, whenever there is a transmural ischemia, what do we see on the ECG?
ST elevation.
BC and ST elevation. Good. Right? Good. Right. Then we'll come to the third one. Our unstable angina. Now someone unmute and tell me what do we mean by unstable angina? Unstable angina is coming from an unstable plaque. What do we mean by an unstable plaque? Anyone? Interact. Yeah. Yes, there's fissuring and rupturing, true. Yeah, go ahead.
I said acute. Acute
what?
The rupturing of it.
Okay. It's more acute compared to something like stable angina. I agree. But what about the nature of the plaque? It has a thin fibrous cap. It has plaque shoulder inflammation, right? plaque showed inflammation. And what does it have? This in this blue color I drew, I don't know if you all can see, it has thrombus formation also. Thrombus on top of the plaque, right? I hope you all remember. Now, guys, I'm telling you all, unstable angina in the initial phases at least, right? There can still be starting with the subendocardial region. Subendocardial region. So if there is subendocardial region ischemia, how do we see it on the ECG? How do we see it? Yeah, okay. Unmute and talk. Okay. Non-ST elevations. Non-ST elevations. Right? Okay. Come to the next one. Now I'm telling you all, here we are coming to the myocardial infarctions. Myocardial infarctions. MI. Right? Now, when do we usually get a myocardial infarction, guys? When the obstruction is quite significant, right? Or if something here isn't managed on time. That is when we get the infarction, right? Here, guys, I'm going to draw it in red. You all also can draw it in red. We can have subendocardial infarctions, right? Or we can have transmural infarctions, right? Transmural infarctions. Now, if you do the ECG here, what are you going to see? For ECG here.
Non-ST elevation.
Non-ST elevation here, right? Non-ST elevation here. Now, since I have given you all the pathology, I have cut a piece of the heart and I have given you all can see the infarction. So you put the word MI. This is a non-STEMI. Okay. Then here, what are you all going to see here? Transmural ST elevation. So this is a STEMI, right? ST elevation MI, right? Now look at the problem. Now what is the problem? Now look at this guy. Here, in the ECG, we can see ST elevations in Prince metal angina. We can see ST elevations in the transmural myocardial infarction, right? Then in the ECG, we can see non-ST elevation. What do we mean by non-ST elevation? What do we see? Non-ST elevation?
Depressions.
ST depressions plus or minus T-wave inversion, right? So in ECG, we can see non-ST elevations where stable angina, unstable angina, and even in a MI, in a subendocardial MI. So now this is a problem. So is our ECG 100% diagnostic? No, right? This is why we need to go to the next test. So when a patient comes, our initial test is the ECG. Any patient coming with chest pain, you're going to do an ECG, right? So from an ECG, there is only so much information you can get. Now what we are going to do next, we are going to check the biomarkers. Biomarkers, right? Biomarkers. When we check the cardiac troponin, whichever is available in the hospital, you will check. So usually in peripheral areas, sometimes guys, they might not have troponin assays, right? Sometimes we have to even transfer the patient depending on how rural the area is, right? Just to get the troponins done, right? So you check the troponins or CK, whatever is available, you check. Best is troponins, especially for a first time infarction, best is troponins. Now, when you check the troponins, okay, tell me one by one. Stable angina. Troponins will be elevated or not?
No.
No. Why no? There is no cell death. There is no cell death. Prince metal angina. Can troponins be elevated or not? Usually no. Here guys, I'm telling you all usually no. For our level, for MBBS level, just know that it's no. Right? But there are some rare occasions of Prince metal angina, right? Where they give biomarkers positive, but not for MBBS. Don't worry. In MBBS level, until your MBBS is complete, if anyone asks, does Prince metal cause biomarkers to increase? You say no. Okay? No. Right? Don't worry. Then, unstable angina. What will happen to biomarkers? Elevated or not?
No.
No. Then here, our subendocardial myocardial infarction. Subendocardial infarction. Elevated or not? Biomarkers? Elevated. Right? Elevated. Right? Then, our full thickness or transmural infarct. What is happening? Biomarkers, guys, here, if you want to specifically draw about 4 arrows. The biomarkers will also show a quantitative increase, right? Very high level of biomarkers when it's a transmural involvement, right? Okay. Right. Understood. Now look at this. Now we have another problem. What is the other problem we have? All of these conditions, right? Now, this guy also have a non-ST elevation and he also has a non-ST elevation. and both have biomarkers negative. Now how to differentiate? What do you think?
Clinically?
Symptoms.
Clinically, yes, to a certain extent. Not necessarily. Usually, unstable angina, they will have a lot more autonomic features. We'll talk about those tomorrow. But a more specific, because there is clinical, you all will understand when you all work in the clinical setting. This ischemic heart disease, clinically, very difficult to differentiate, guys, because pain thresholds in patients are different, right? Some patients for a minor ischemia, they will complain like the severe, they will complain of a very severe pain, whereas some patients not like that. You all might have heard, guys. I will just deviating a little bit from the topic. You all have heard of diabetic neuropathy. Right? These patients with diabetic neuropathy, their pain sensation is very much reduced. Sometimes they have what you call a silent heart attack, and they even die. They don't even know that they've been suffering from ischemic heart disease, right? Diabetic patients. So pain threshold is different. So clinically, it's a little bit difficult. Any other method you think we can?
Echo?
Yes, no, we'll go there later. Echo is different. Simple thing, guys. Simple thing. What is the drug we give to almost all people with chest pain? We talked about it today.
Oh, nitrate.
Nitrates. You give them a nitrate, right? You put a nitrate here. You give them a nitrate, right? You give them a nitrate. Now you check which pains are relieved, right? If you look at the stable angina, when you give a nitrate, will the pain relieve or not? What will happen?
Yes.
Yes, pain is gone. Right? Pain relief happens. If you check unstable angina, you give a nitrate, pain gone or not? Pain will not be relieved for unstable angina by just a nitrate. Okay, pain is not relieved. Then, guys, another important thing: Prinzmetal angina. What do you think? If you give a nitrate, what will happen? Yes. What is? Just think about the mechanism. Prinzmetal angina was what? A vasospastic condition. If you are giving a nitrate, will the pain relieve or not? Logically, don't think too much. Don't overthink. Now, in Prinzmetal, was there a plaque? Was there an atheromatous plaque? Nothing. Just a vasospasm. So, if you give a nitrate, will the pain relieve or not? Will be relieved. What do you all think? Yes, it's okay. Answer. Guys, don't be afraid to answer. Huh? Answer. And let me ask someone. Guys, you all are understanding what I'm asking, right? That's what I'm afraid of. When you all are silent. Shabib, what do you think? Yes. Prinzmetal angina patient, we gave a nitrate. Pain relieved or not?
No.
Why not? Why do you say no?
For this spasm only in the coronary.
Okay. Right. Now,
Yes.
wait. Okay. So, okay, wait. Nitrates. Now, what did we talk about nitrates? Nitrates can cause vasodilation in the entire body, including the coronary vessels, except for the areas with the atheromatous plaque. Right? That's what we discussed now. Now, if there is a coronary vessel like this, if there is an atheromatous plaque, this area from here to here will not be vasodilated from the nitrate. The rest can be. That is not a problem. Right? So now, based on that, what do you think? Guys, this will work. For nitrates, if you give for a Prinzmetal angina patients, if you give a nitrate, the pain will go away. Nothing complex. There is no atheromatous plaque. It's just the vasospasm. The vessel has constricted. Now you gave a nitrate, it will dilate. No problem. Okay. Senior students, 5th year, Sachit. Can we give beta blockers to a Prinzmetal patient? Any idea? No, For now, just no. No. We cannot give beta blockers to a Prinzmetal patient. There is a mechanism. We'll not talk about that today. Alpha receptor stimulation is there. It can actually worsen the Prinzmetal angina. Okay. Not required for today's lesson. Anyway, now using ECGs and biomarkers and nitrates, can we come to a very conclusive diagnosis? What do you all think? Yes, right? Yes, right? We can differentiate 5 conditions, right? Using these 3 methods. Okay, right? So this is our basic diagnostic, guys. You have to be, now I have put on your skeletal note, the one I sent in the group, I have put a big table on the last page, a big graph sort of thing. This is that. This is that in simple terms. Okay. If you all understand this, you all are good to go in the clinical setup, right? Okay. Then guys, right, we'll talk about the last portion for today, the diagnostics and management of stable angina, and then the rest will be tomorrow. This is nothing much now. We have already talked about. You all can even, nothing much to write down, guys. You all can just open up your notes, right? I have put the major stuff there. Right? Everyone clear up to this point? Huh? How are you all? Brains overloaded, brains dying, no? Nothing wrong, no? All good? Right? Okay, give me a thumbs up. I see some faces like this. Okay, right. Okay, let's move on. Finally, now we are coming, we'll just talk about the diagnostics because guys, tomorrow we are going to talk about acute coronary syndromes because that is emergency medicine. That's a little bit more advanced. Today we'll finish off the diagnostics and management of stable angina. We have already talked a lot, right? Just to summarize. Stable angina, diagnostics. What did we talk about now? First thing, ECG. ECG. What are you going to see in an ECG in stable angina? What are you going to see? What are you going to see?
ST depressions.
ST depressions plus or minus, don't forget, ST depression plus or minus T wave inversion. T wave inversion. Okay, plus or minus T wave inversion. Then, now tell me this, guys. Stable angina patient. Will you ever meet in the clinical setting a stable angina patient telling you, doctor, my chest is paining, that's why I came now. My chest is paining right now. Will you ever get a patient like that? Stable angina. Why not?
Because it's a chronic condition, it would have taken place over a long period of time.
Yes, correct. Also, what is the feature of stable angina, guys? It is provoked by exertion. It is stable at rest. So unless the patient comes running a marathon to the hospital, right, running all that way with the pain, and he is presenting to you saying, okay, my chest is paining, most of the time they'll be walking and coming, or coming in a vehicle or something. By the time they are at the hospital, there is no pain, right? So if you do the ECG after the patient comes and he's having no pain, will you see this? ST depression and T inversions? Will you see it? What do you think? Will you see? Any guesses? No, guys, we won't see. We won't see if the patient is well rested and he comes to you. There is no chest pain. You do the ECG, you won't see anything. Then what do we need to do? What is the specific ECG that we need to do in this patient? We need to do something called the stress ECG, guys. Stress ECG. What does that mean? We put them on a treadmill. Put them on a treadmill with all the ECG leads connected. You induce his ischemic condition, and then you will see the ST depressions and the T wave. Okay, clear? Right? The stress ECG. Then the second one, echocardiography. Echocardiography. Now some of you all mentioned before also. Echocardiography also. What will we see in the echocardiography? What are we looking for? We talked about at the start. When there is ischemia, what is happening? What's the word? I want you all to get familiar with the words. Tell. Unmute and talk. Guys, I see you all mouthing the words, but you all are muted. Echocardiogram, what are you going to see? Tatsarani. What will you see? Or what are you looking for?
Necrosis.
Echocardiogram, we won't see cell death or necrosis. Right? What is echo? Echo is, guys, this is a 2D imaging. What you see the motion of your heart. Right? I will send some videos then in the group later. So you all can see the systolic motion, the diastolic motion of the heart walls you can see when you do the echocardiogram. You won't see cellular structure. You won't see necrosis of the cells. No. Right? So what you're seeing is here, we mentioned a little bit earlier, whenever there is ischemia to a portion of the cardiac muscle, what is going to happen? That part is not good. Hypokinesia, that part is not going to contract well. So what are you going to see? Hypokinesia of the ventricular muscle wall, right? Okay. So this hypokinesia, again, will you see in every patient who is coming and telling, doctor, yesterday I had a chest pain? No. Again, what? Stress echo, right? Again, same concept. We put them on a treadmill, do the echocardiogram. Okay, right? This is stress ECG and stress echo. Everyone clear? Right. Then the next one. Here, guys, these are some advanced ones. In Sri Lanka, we don't really do them. There is some, but you all might need to, especially in your final exams in your countries, Russia, China, you all need to know this, right? Myocardial perfusion scanning. Here, guys, we use some radioactive materials, some technetium-99, right? There's thallium, right? Right? Radioactive substances. We inject them, right? And we will see them on the scan. What are we going to see? Students from China. If you all have visited the radiology, who I'm not sure who's Tarushika, you're from China, right? Yeah, sorry, Tianjin, right? Been to the hospital, radiology? You've seen the technetium scan? No? No. Okay. Sachit, seen technetium scans? No?
Not this specific one.
What have you seen?
I have seen the CABG. Sorry,
It's okay. Okay. So you've seen something different. Okay. Here, guys, this technetium and thallium. So actually, yeah. So I'm from Nanjing. Nanjing Medical University, if you all don't know me. So I've actually seen the technetium and the thallium being used. Here there are these two. They work in opposites actually. So what you do is they inject the dye, right? They inject the radioactive material right behind the glass wall and everything, right? If you all have the chance to go to hospital, go and see. And the ischemic portion will either take up or will not take up this substance. So specifically, guys, what I mean by that is if you inject technetium, let's say the infarcted portion is here. This is the infarcted portion. If you inject technetium, this technetium will be taken up by this infarcted portion, right? And it will appear as what we call hot. We call this in radioactive terms, we call it a hot spot, right? In the perfusion scanning, you see it as a hot spot. Whereas thallium, it's the opposite, guys. Thallium, when you inject, the ischemic portion won't take it up. The normal myocyte areas will take up that thallium, right? The normal myocyte, the ischemic portion will be left blank. So this is called a cold spot, right? Very interesting, right? If you all get the chance, go and see. So anyway, that is another one. Sri Lanka, of course, very rarely done. Private hospitals, we do have it, but not commonly done. Technetium and thallium is the common ones. There are other materials as well, like Sachit said, there are other stuff. But just know what the name is at least, right? And then, guys, invasive, the other last option, the invasive procedure we have is angiography, right? What is this angiography, guys? We choose a blood vessel. Specifically, most of the time we choose the femoral artery, right? So we insert a catheter through the femoral artery and it will go all the way up through the aorta, right? Okay. And it will come up to here and it will inject a dye. Right? We will inject a dye. Then from that dye, guys, you can nicely see the coronary arteries, right? And we will be taking x-rays, right? We will be taking sequential x-rays and we can see the coronary arteries nicely. And if there is a thrombus, you will see an obstruction. From there on, from that obstruction point on, the dye will not go. Okay. So that is angiography. That is an invasive procedure. Since we are giving a dye and everything, right? We have to do the renal function tests beforehand, right? Multiple things to do, right? So those are the basic diagnostics I want you all to know when it comes to stable angina. Then, guys, basic concepts of management. Don't worry, tomorrow we are going deep into this diagnostics and management. And tomorrow we'll do the emergency medicine part and how to take history, all of that. For today, now the next last thing is management. MX. Management, right? How do we manage? Patient coming with chest pain. You did the ECG, you did the biomarkers, you have done the angiography, you diagnosed this as stable angina. There has been a plaque for a long period of time. Symptoms have been there for a long period of time. How are you going to manage it? How will you approach the patient?
Nitrates first.
Okay.
Lifestyle
Okay.
modification.
Sorry? Yes. First thing you advise the patient. True. If the patient is currently having chest pain, yes, we can give them a nitrate. But majority of the time, what did we say? Stable angina patient, when they are coming to you, no chest pain, right? So at that point, no need to give a nitrate. But we will prescribe them a nitrate in our medication. But how we approach the patient is firstly advise on lifestyle modifications. What are lifestyle modifications? We talked about risk factors at the start. Remember the modifiable risk factors? Try to modify all of those. Whatever the patient has, modify that. He has diabetes, optimize his diabetes control. He has hypertension, optimize the hypertension control, right? You add a drug. So if he's having diabetes, if he's only on metformin, add another drug, GLP-1 receptor agonist, something, cardioprotective drug, right? Like that. So what if he's smoking? Alcohol consumption. Right? Stop. Right? Stop. Previous guidelines was stop smoking and reduce alcohol. Now it is stop both. Stop both. But again, guys, for those, you need your senior guidance as well, because if the patient is severely addicted, right? So for example, say alcohol addiction, right? If they're severely addicted, you can't stop them at once. If you stop them at once, there are other problems. There can be withdrawal seizures, right? There can be delirium tremens, like various other problems will come. So you have to step by step, you have to stop them, right? So now this was one of the questions they asked me in my final MBBS exam, right? How are you going to manage the stable angina? Because everyone memorizes emergency management for the acute coronary syndrome and goes to the exam. And they ask this. So you have to start with here, lifestyle modification, right? What are you going to tell the patient? How are you going to advise, right? All of that. Then, you manage any underlying condition. If the patient has diabetes, manage that. If the patient has hypertension, manage that. Dyslipidemia. What do we give for dyslipidemia? We'll put a few of those also, guys. Okay. Lifestyle modification, right? Okay. Next thing. Now look at this, guys. Now think of the stable plaque. What was one of the major differences between the stable plaque and the unstable plaque? What was one of the major differences? The fissuring and the thrombus, right? You all remember the unstable plaque had a very large thrombus on it. So we want to stop this stable angina plaque also going to this unstable state. We want to stop that, right? So if we want to stop this thrombus formation like that, what can we give? Antiplatelet medication, right? We can prescribe some antiplatelets. So usually, guys, for these stable angina patients, we can give a low dose aspirin, right? Low dose aspirin, right? Now, how aspirin works, right? We'll talk about later. It's a cyclooxygenase inhibitor you all might have heard of, right? What does aspirin do, guys? Aspirin, remember we talked about TXA2, thromboxane A2 produced here, right? Aspirin will reduce this thromboxane A2, right? Aspirin reduces thromboxane A2. So it will prevent vasoconstriction. It will prevent platelet aggregation, all of these things. Right? Then what is another drug? With aspirin, always going hand in hand with that. Sorry? Warfarin? No, not here, right? We always going hand in hand with aspirin. Warfarin we'll talk about tomorrow. In acute coronary syndromes, we'll talk about that. For now, aspirin and always clopidogrel. Have you heard? Clopidogrel, right? What is this clopidogrel? Remember in our pathophysiology, we talked about something called glycoprotein 2B3A released by the platelets that helps platelet aggregation. This clopidogrel inhibits glycoprotein 2B3A. Okay, thereby causing what? Preventing this platelet plug formation. Okay, understood? Asclepius, right? Usually low dose, guys. This is not the acute condition. Usually around 50 to 70, somewhere 75 milligrams is enough, right? Then, okay. Then, what is the other problem we saw? Dyslipidemia. So what can we give? Statins. Have you all heard about statins? Huh? What are the statins you all have heard of? Huh?
Atorvastatin, rosuvastatin.
Yeah, most commonly used ones in Sri Lanka, right? atorvastatin, rosuvastatin. Apart from that, we have simvastatin, pitavastatin, lovastatin. There's several. Right. So statins. What do statin do, guys? It will reduce the triglycerides. It can reduce the LDL, right? And it can help increase the HDL as well. It can help increase the HDL as well. So basically, what is it doing? Reducing the bad cholesterol and keeping the good cholesterol, right? Here, guys, statins have another function. Anyone is aware of that? Apart from cholesterol-related things, statin has another function. Anyone aware? Anyone? It has, guys, some anti-inflammatory properties. Anti-inflammatory properties specifically. Where was our inflammation problem when it comes to unstable angina and the unstable plaque? Where was it? Do you all remember? Where was the inflammation problem? Yeah, Shabir? Where was the inflammation problem, guys? When it comes to... Sorry?
The vessel.
Yes.
Plaque shoulder.
Plaque shoulder. Yes. With the vasovasorum, yes, correct. That is involved. But mainly the plaque shoulder area. So this one has some anti-inflammatory properties. Specifically, it will act around this plaque shoulder area. When the inflammation is reduced around the plaque shoulder, what will happen? The plaque will become a little bit more stable. Right? Okay. So it prevents plaque shoulder inflammation. Okay. Right. Then we'll also want to, what else? Guys, you all have written, right? Yeah. I will erase this. Then we also want to do what, guys? We want to vasodilate a little and we want to reduce the blood pressure also a little, right? So what are we giving? Here we can give anti-hypertensives, or what we call, in this case, they also act as anti-anginals, right? Anti-hypertensives or anti-anginals. So what are our top options? One is, you all already said, nitrates, right? Here, guys, most of the time we use GTN, glyceraldehyde trinitrate, right? Glyceraldehyde trinitrate. Or we have isosorbide mononitrate, right? Isosorbide mononitrate. Just fancy words, fancy names. Just know the, if you all know GTN, if you all know ISMN, that's enough. Okay. Then we also have isosorbide dinitrate. We have a lot, right? Nitrates. Then how nitrates act? Now you all know. Okay. How nitrates act? Systemic vasodilation and venodilation. Right? Then another one. Beta blockers. We can give some beta blockers. Beta blockers we can give for all conditions except Prinzmetal angina. Except for Prinzmetal angina, we can give beta blockers, right? We will not discuss that today, guys, that mechanism. If anyone wants, just drop me a message if you are interested, right? I will explain, because it's a little bit of a deep topic. Okay, so beta blockers.
Calcium channel blockers.
Yes, calcium channel blockers. Before we come there, yes, you're correct, CCBs. Before we come, beta blockers, guys, specifically, we want what we call cardioselective. What do we mean by cardioselective? Now, this guy's problem is in the coronary arteries, right? So do we want to give beta blockers to go and vasodilate everywhere in the body? No. So we want specifically beta blockers that work on the cardiovascular system, right? Specifically the heart. So we call this cardioselective beta blockers, right? What are these cardioselective beta blockers, guys? Right? There are multiple, right? So as a general rule, this is not 100%, but I want, if you all want, you all can use this method, because I use this in college as well. From the letter A up to the letter M, right? A to M. 99% of the beta blockers from the letter A to letter M are cardioselective. So you have atenolol, bisoprolol, carvedilol, metoprolol. All of these are cardioselective. After M, there are some beta blockers. Those are non-cardioselective. This is a general rule, guys. Okay. Sometimes, I don't know, if I make a beta blocker tomorrow, I might name it something else, right? We don't know, right? But as a general rule for you all to remember, that is how I used to remember, right? A to M. Specifically, atenolol, bisoprolol, carvedilol, and metoprolol, right? There are a lot more, okay? These are cardioselective. Okay, right. Then calcium channel blockers, yes, you're correct. That's the next one. Again, we want Cardioselective calcium channel blockers. What are these guys? We call these non-dihydropyridine, non-DHP, non-dihydropyridine calcium channel blockers. Okay, so we have verapamil, right? One is called verapamil. One is called diltiazem, right? Verapamil and diltiazem, right? These are non-dihydropyridine calcium channel blockers. These are the ones we like to use. Okay. How do these calcium channel blockers work, guys? In stable angina? What do you think? Very simple concepts.
Reduce muscle contract.
Excellent. Reduce the myocardial contractility, thereby reducing workload. So the oxygen demand is dropped. Oxygen demand is lower because these stable patients, they have a stable plaque. We are not worried about it rupturing and going anywhere, right? So just reduce the workload a little bit. That's how CCBs work, right? Here, guys, I erased that. No, that is. Okay, here, guys, just write down. Initially, I wanted you all to just circle. But generally, for all patients that we diagnose stable angina, we start them on some of these drugs. One is low-dose aspirin. Almost all the patients, we start them on low-dose aspirin, right? The other one is we give them a GTN, right? Almost all the patients, we give them a GTN. Specifically, we tell them if you are going to do an exerting activity today, let's say it's a farmer. Let's say every 2 weeks, he's going to his farm to do some work. So we tell them prophylactically, right? They can take some GTN before that day that they're going for exertional activities, right? Then, so every patient gets low-dose aspirin, GTN, and almost everyone gets a beta blocker. We put them on a beta blocker, right? And we put them on statins. All patients, guys, these four, we almost for everyone we give if we diagnose them as stable angina. Statin, beta blocker, GTN, and low-dose aspirin, right? The others we add according to the patient, based on the patient's profile, right? It will vary from one patient to another. Okay, clear? Okay. This, guys, we can try this management. So once stable angina is diagnosed, we tell the patient to come for routine checkups. So we want, specifically if the first episode was yesterday, we will tell them come again after prescribing these medicines, come again in another 2 weeks. We need to do another stress ECG, right? Like that, and another 1 month, then another 3 months, right? Right, that we are going to ask them to come follow up. If there is no improvement in the pain, even with these medications, right? We can again, finally, as a last option, go for something called PCI, percutaneous coronary intervention, even for stable angina patients. This is rare. 95, 96% of them will be fine with these medications. But if it doesn't improve, we have this PCI option. This we'll talk about tomorrow with our acute coronary syndromes, right? Did everyone understand up to this? All good? Any question? You all have any question from this class today? So there are some messages. Yeah. Can you please explain this once more? Explain what? Which part? I'm not sure. Guys, if there is something you all are unclear about, then and there unmute and let me know. It's done. Okay. So you understood, right? Okay. Right. Guys, show me your faces. Only few faces visible so that I know who you all are. Right? So that's about it, guys, for today's class. Tomorrow, we are going to start off with acute coronary syndrome, right? We are going to talk about the diagnostics, the emergency management. We're going to talk about how to take the history, right? And some complications also. Okay. So that's about it for today. Just give me a small feedback if you all can, right? I would be really grateful. Just drop me a message about how the speed was, how the lecture content was, right? Tomorrow we'll do the rest. But how today's session was, the lecture duration, anything, right? Anything that you all enjoyed or didn't like about the lecture, just let me know, because I'm also starting again after like 2.5 years now. I've forgotten to teach a little. Sachit, any difference from Shabib? Any difference from the past 2.5 years? No, nothing. Is that good or bad? Is it okay? Okay. Right. Just drop me a message, guys. Just let me know if there is anything I can improve, right? So we'll be having occasional free sessions like this, as well as I'll be doing some paid programs as well. So we'll see how it goes. Right. So that's it for today. I will see you guys again tomorrow, same time, 4:30. Right. Tomorrow will be a little bit advanced. If y'all still have any seniors who didn't join, they are welcome to join tomorrow. Right. Yeah. So that's about it. Okay, then. See you guys. See you all tomorrow. Yeah.
Thank you.
All right. You're welcome.